ഓക്കെ. അപ്പോ എനിക്ക് തോന്നുന്നു കുട്ടികൾ ജോയിൻ ചെയ്യുന്നേ ഉള്ളൂ. ഞാൻ ആക്ച്വലി കുറച്ച് റേഞ്ചിന്റെ പ്രോബ്ലം ഉണ്ട് എനിക്ക്. ഐ തിങ്ക് കുറച്ച് പേരെ ആയിട്ടുള്ളൂ. യൂഷ്വലി വി സ്റ്റാർട്ട് ബൈ 7 o'clock. മേ ബി ഐ വിൽ പുട്ട് എ മെസ്സേജ് വൺസ് അഗെയിൻ. നമുക്ക് കറക്റ്റ് ആയിട്ട് തുടങ്ങാം. കുട്ടികൾ ജോയിൻ ചെയ്യട്ടെ. നമുക്ക് ENTക്ക് ഒരു ക്ലാസ്സേ ഉള്ളൂ. ഒത്തിരി പേര് എനിക്ക് മെസ്സേജ് ഇങ്ങനെ അയക്കുന്നുണ്ടായിരുന്നു. കുറെ പേര് ക്ലാസ്സിൽ കയറുന്നവർക്ക് അത് പിന്നെ ക്ലാസ്സുകൾ കേൾക്കാൻ ബുദ്ധിമുട്ടാണ്, അപ്പൊ അതുകൊണ്ട് കേൾക്കുന്നവർക്ക് ഉപയോഗം ഉണ്ടെന്നും പറഞ്ഞ് മെസ്സേജ് അയച്ചിരുന്നു. ബട്ട് സ്റ്റിൽ കുട്ടികൾക്ക് ലാസ്റ്റ് വരെ ഇപ്പോഴും ഡ്യൂട്ടി എടുക്കുന്നുണ്ട് പലരും. അതുകൊണ്ടാണ് അവർക്ക് ഡ്യൂട്ടി ചേഞ്ചിന് ടൈമിൽ ഈ പ്രോബ്ലം വരുന്നത്. അപ്പൊ അന്ന് ബിജോൺ സാർ പറഞ്ഞ പോലെ ഡ്യൂട്ടി എനിക്ക് തോന്നുന്നു എടുക്കുന്നതൊക്കെ നിർത്താറായി. കാരണം ഓൾറെഡി എന്തായാലും സമയത്തിന് തന്നെ എക്സാം നടക്കും എന്നുള്ളത് ഏകദേശം ഉറപ്പായി. അപ്പോ നമുക്ക് ക്ലാസ്സസ് അപ്ലോഡ് ചെയ്യുമെങ്കിലും ഈ ഒരു കുറച്ച് സമയം കൊണ്ട് ENT മുഴുവനും മനസ്സിലാക്കാൻ പറ്റുന്ന ഒരു രീതിയാണ്. അത്യാവശ്യമുള്ള സ്ഥലങ്ങൾ മാത്രം നമുക്ക് പഠിക്കാൻ പറ്റും. പിന്നെ അതുപോലെ സിമ്പിൾ ക്വസ്റ്റ്യൻസ് നമുക്ക് തെറ്റിപ്പോവാതിരിക്കാനും പറ്റും. ഇറ്റ്സ് ഇമ്പോസിബിൾ ടു കവർ എവറിത്തിങ് ഇത്രയും ചെറിയ സമയത്ത്. മാഡം ഇങ്ങനെ ഒരു ക്ലാസ് എടുത്തരാന്ന് പറഞ്ഞതേ വലിയ കാര്യം. ഐ നോ ഷീസ് എ വെരി ബിസി പേഴ്സൺ. പോലെ എനിക്ക് തോന്നുന്നു മാഡം ഇന്നും തിരക്കായിട്ട് നിന്നതാണ്. എന്നിട്ടും മാഡം ക്ലാസ് എടുക്കാൻ വേണ്ടി സമ്മതിച്ചു. മാഡത്തിന്റെ ENT ക്ലാസ്സസ് യൂട്യൂബിലും ഉണ്ട്. അത് അതിന്റെ ലിങ്ക് നമ്മൾ ഷെയർ ചെയ്യുന്നതായിരിക്കും. കുറച്ചുകൂടെ ഡീറ്റെയിൽ ആയിട്ട് സാർ മാഡത്തിന്റെ ക്ലാസ്സസ് എല്ലാം അതിനകത്തുണ്ട്. ഡോക്ടർ സുജാതാസ് ENT ക്ലാസ്സസ്. അപ്പോൾ മാഡം എൻ്റെ ടീച്ചറാണ്. അതുപോലെ തന്നെ ഈ ക്ലാസ് തുടങ്ങാനായിട്ട് എനിക്ക് എല്ലാ സപ്പോർട്ടും തന്നത് മാഡമാണ്. ഇതിപ്പോൾ നമ്മൾ 4th സീസൺ ആയി. ഫസ്റ്റ് സീസൺ മുതൽ മാഡത്തിന്റെ സപ്പോർട്ടോട് കൊണ്ടാണ് നമുക്കിത് ചെയ്യാൻ പറ്റിയത്. അപ്പോൾ സമയം കളയുന്നില്ല. മാഡം കാണാൻ പറ്റുന്നുണ്ടോ?
കാണാം സ്വപ്ന. യു ആർ സോ നൈസ്. വണ്ടി പിടിച്ചോ.
താങ്ക് യു മാഡം, താങ്ക് യു. എനിക്ക് ഒട്ടും റേഞ്ച് ഇല്ല. അപ്പൊ എന്തായാലും ക്ലാസ് നമുക്ക് തുടങ്ങാം. തുടങ്ങിയിട്ട് കുട്ടികൾ ജോയിൻ ചെയ്തോളും. ദ ഹോൾ ക്ലാസ് ഇസ് റെക്കോർഡഡ് ആൻഡ് റീപ്രൊഡ്യൂസിബിൾ. യു ക്യാൻ വ്യൂ ഇറ്റ് ടിൽ യുവർ എക്സാംസ് ആർ ഓവർ. ഓക്കെ. കഴിഞ്ഞ പ്രാവശ്യത്തെ ക്രാഷ് കോഴ്സസിൽ കുട്ടികൾ ഇപ്പോഴും കാണുന്നുണ്ട്. ദേ കനോട്ട് ഡൗൺലോഡ് ഇറ്റ്, ബട്ട് ദേ ക്യാൻ വ്യൂ ഇറ്റ്. അത് കഴിയുമ്പോഴേക്കും അവർക്ക് ആ വ്യൂവിംഗ് പെർമിഷൻ പോകും. സോ ഓവർ ടു യു മാഡം.
ഗുഡ് ഈവനിങ് ഓൾ.
സൗണ്ട് ഓക്കെ ആണോ? എനിക്ക് കുറച്ച് കുറവായിട്ട് കേൾക്കുന്നുണ്ടോ? ഓക്കെ ആണല്ലോ അല്ലേ? ആരെങ്കിലും മെസ്സേജ് ഇടുന്നേ.
I think, is it okay? Assuming that sound is okay.
Yes, madam.
I'll continue with this. So this 120 minutes class, the objective may be list of, I'll just explain important topics in ENT because ഒറ്റ ക്ലാസ് വെച്ചിട്ട് നമുക്ക് ഇത്രയും കവർ ചെയ്യാൻ ബുദ്ധിമുട്ടാണ്. അപ്പൊ എന്തൊക്കെയാണ് ഇമ്പോർട്ടന്റ് ടോപ്പിക്സ് എന്ന് പറയാം. അപ്പൊ അത് വെച്ചും കൊണ്ട് യു ഗോ ത്രൂ ഈച്ച് ടോപ്പിക്. And today I'll try to cover development and anatomy of ear and nose, which is very important topic. Then another important area is implantable hearing devices, then allergic fungal rhinosinusitis, like small topics. And also we will go through most asked MCQs. And if you want some areas specifically to cover, just message it to anyone in this group, or especially to Dr. Swapna, so that if time permits, we can give, or I'll give you notes also. Okay. So we know it is on June 15, 800 marks of 200 questions. And negative marking is also there. അതുകൊണ്ട് വൈൽഡ് ഗസ്സുകൾ ഒഴിവാക്കാൻ ശ്രമിക്കുക. അതൊക്കെ നിങ്ങൾക്ക് അറിയുന്നതായിരിക്കും. 3.5 മണിക്കൂറിനകത്ത് ഏകദേശം 1 മിനിറ്റ് ആണ്. So you will get around 1 minute for each questions. 1.05 ആണ് കാൽക്കുലേഷനിൽ വരുന്നത്. So it's around 1 minute. So ഈ ഒരു സമയത്തിന് we have less than 2 months അല്ലെ? Less than 2 months ആണ്. അപ്പൊ അതിനകത്ത് മാക്സിമം get a timetable and try to revise questions. അപ്പം കുറെ അധികം എപ്പോഴും ചോദിക്കുന്ന ഏറ്റവും ആവശ്യമുള്ള ഏരിയാസിലാണ്. അതെല്ലാം റിവൈസ് ചെയ്യുക. വൈഡായിട്ട് വായിക്കുന്നതിന് പകരം അതെല്ലാം റിവൈസ് ചെയ്യുക. ആൻഡ് ഇൻ ENT you have 10 questions, 10 marks will be there. Okay. So, ഇതിനകത്ത് ഏറ്റവും important ആയിട്ട് വരുന്നത് anatomy of ear, then physiology of hearing will be there. Then test of hearing loss, especially in newborn, that's also very important. Then diseases of external ear, acute suppurative otitis media, chronic suppurative otitis media, complications of chronic suppurative otitis media, adhigam important. Kore questions ainathnu kaanarundu. Otosclerosis, you can expect minimum 1 question from there. Then Meniere's disease, glomus tumors, another important one. Then acoustic neuroma. It is also vestibular schwannoma or acoustic neuroma. That is also important area. Then facial nerve and its disorders. Then rehabilitation, especially deaf child, rehabilitation of the deaf child. ഇതെല്ലാം നിങ്ങൾ നോക്കി പോകേണ്ട ഏരിയാസ് ആണ്. ഇതിന്ന് എപ്പോഴും റിപ്പീറ്റഡ് ആയിട്ട് MCQs ചോദിക്കുന്നതാണ് കാണുന്നത്. പിന്നെ വരുന്നത് anatomy and physiology of nose, epistaxis or bleeding from the nose, then sinusitis, especially allergic fungal sinusitis, then rhinitis, deviated nasal septum, rhinosporidiosis, rhinoscleroma, inverted papilloma, maxillary sinus, carcinoma of maxillary sinus, especially the classification and prognostic lines. Ongren's line ഒക്കെ എപ്പോഴും ചോദിക്കുന്നതാണ്. Surgeries and incisions, because especially in any set, image guided questions will be there. You will be given an image of something, image of some incisions, image of some histopathology slide images. അപ്പൊ അതിനകത്തെല്ലാം അതെല്ലാം നോക്കിയിട്ട് പോകണം. അതിനകത്ത് ഈ നോസിനകത്ത് പ്രധാനമായിട്ടും ഇത്രയാണ് ചോദിക്കുന്നത്. ഇതിൽ തന്നെ ഏറ്റവും പ്രധാനമായിട്ടുള്ളത് rhinosporidiosis, rhinoscleroma asked so many times, and also maxillary sinus carcinoma. പിന്നെ pharynx anatomy, then nasopharyngeal angiofibroma, nasopharyngeal carcinoma, then tonsillitis, spaces around the pharynx, retropharyngeal abscess, quinsy or peritonsillar abscess, and Ludwig's angina. ഇതെപ്പോഴും ചോദിക്കുന്നതാണ്. ഇത്രയും ഭാഗങ്ങളെങ്കിലും നിങ്ങൾ MCQs ആയാലും മതി, ഒന്ന് വായിച്ചു പോയി കഴിഞ്ഞാൽ ക്വസ്റ്റ്യൻസിന് ആൻസർ ചെയ്യാനായിട്ട് പറ്റും. പിന്നെ ലാരിങ്സിലെ anatomy again, vocal cord palsy, it's very important area. So many times repeatedly questions are asked from vocal cord paralysis, carcinoma larynx, especially the staging of carcinoma larynx. That's very important. Then the congenital malformations of larynx, then the voice disorders, then croup or acute laryngotracheobronchitis and epiglottitis. Adinum scenario-based questions are usually asked. And tuberculosis larynx, esophagus anatomy, physiology, and dysphagia. So ഇത്രയും topics എങ്കിലും വായിച്ചിട്ട് പോകണം minimum ENT ക്കകത്ത്. So we will start from the development and anomalies of ear. This is also very important. So you know that pinna development starts from 4th to 6th week of intrauterine life, and that is from the first and second branchial arches. So only the tragus develop from the first arch. Okay, tragus develop from the first arch. So this part, here comes the tragus. Okay, so idinathu first arch, and from the first and second arches there are around 6 ectodermal tubercles arises. Okay, so here also you can see 1, 2, 3, 4, 5, 6 tubercle. That is from first and second arches. So this part from the first arch comes the tragus. And see, this is in the development, this is the tragus. So the tragus develop from the first arch, and the rest of the pinna develop from the second arch. Okay. So mainly the tragus develop from first arch. So majority of pinna develop from the second arch. Okay. Only the tragus develop from the first arch. So what is the commonest anomaly in this area? What is this one? Anyone? Can, if possible, you can send in the chat box. That is preauricular sinus. So you can see that this preauricular sinus developed between the tragus and the rest of pinna. So that is something related to developmentally between the first and second arch. Okay. So improper fusion between the first and second brachial arches lead to this preauricular sinus. Okay. So that is usually asked, the improper fusion or defective fusion between the first and second brachial arch that is leading to preauricular sinus. And another one usually asked is pinna. Pinna is fully formed at birth. Okay, pinna is fully formed at birth, but it achieves adult size by 5 to 6 years. Okay, so that is why autoplasty or correction of the malformed pinna is usually done after 5 to 6 years of life. Okay, because once the pinna reaches adult size, only after that we can do correction of the congenital malformation. So that is autoplasty. So autoplasty is usually done after it reaches adult size. That is usually by 5 to 6 years of age. Okay, so that is regarding the development of pinna. Next is after pinna, that is the external auditory canal. In this, you can you have to remember that the external auditory canal developed from the first brachial cleft. Okay. This external auditory canal, here comes it. So this from the first pharyngeal cleft. Okay. So this is this one. Here there is a meatal plug. Then this meatal plug recanalizes. First it is a solid meatal plug. Later it recanalizes. So remember that this external auditory canal is developing from the first pharyngeal cleft. So here usually comes what is this col-oral fistula. One that is usually asked question, col-oral fistula. So this col-oral fistula is a communication between the external auditory canal and the neck. Okay, due to incomplete resorption of the ventral portion of the first brachial cleft. Okay, so anything related to external auditory canal may be due to defective fusion of the first pharyngeal or the first brachial cleft. It is cleft. Okay, so the external auditory canal is from the first pharyngeal cleft. And also remember, col-oral fistula. Fistula means it is a, you can remember a tube with two openings. So the upper or the outer opening will be in the floor of the external auditory canal and the lower opening will be in the neck, that is between the mandible and the sternocleidomastoid. Okay, so that is col-oral fistula. That is an opening. One opening is at the floor of external auditory canal. That is something coming here. And the inner opening or the lower opening will be in the neck between the mandible and the sternocleidomastoid. So that is col-oral fistula. Then comes the development of tympanic membrane. And tympanic membrane developed from all the three germinal centers. Okay, so there is an outer cuticular layer. You know that outer epithelium or the cuticular layer. And the middle fibrous layer, that is the mesoderm, and the inner mucous layer, which is towards the middle ear. So it developed from all the three germinal layers, that is tympanic membrane. And you can, sometimes it is asked as there is a white mass behind an intact tympanic membrane, and that is congenital cholesteatoma. See, all these sentences can be asked as MCQ. Okay, all these sentences are actually asked as repeatedly asked as MCQ. That is why I have written these as sentences like that. So all these sentences are very important. You can get questions from that. Okay. So a white mass behind an intact tympanic membrane is congenital cholesteatoma, right? And the commonest site of an congenital cholesteatoma is middle ear. And other sites are, they can also happen in the skull base, jugula fossa, petrous apex, and CP angle. And in the CP angle, this congenital cholesteatoma is the third most common lesion. So in the CP angle, varuna lesions in the order ana. The most common lesion in the cerebellopontine angle is acoustic neuroma. Then second commonest is a meningioma. And the third commonest is congenital cholesteatoma. Okay. So in congenital cholesteatoma, you have to remember that it's a white mass seen behind an intact tympanic membrane. And it is commonly, the commonest site of a congenital cholesteatoma is middle ear. And the third most common lesion in the CP angle. And the most common lesion in the CP angle is an acoustic neuroma. Okay, so ഇവിടെ ഒരു കൺഫ്യൂഷൻ വരാൻ സാധ്യതയുണ്ട്. ഇതുപോലെ തന്നെ റിപ്പീറ്റഡ് ആയിട്ട് ചോദിച്ചിട്ടുണ്ട്. So just remember that. Okay. Then and in the inner ear, the development regarding the development of inner ear. So the development of the inner ear starts by around 3rd week of intrauterine life, and it is completed by 5 months. That is around 16 to 25th week. And this membranous labyrinth developed from the cranial ectoderm to form the otosys. So you just remember that the first inner ear or the labyrinth is the first special sense organ to differentiate in the body. That because, and that is why the fetus starts hearing by 20th week. ഈ ഒരു കാര്യം നിങ്ങൾക്ക് മഹാഭാരതത്തിലുള്ള മറ്റേ അർജുനന്റെ മകന്റെ കാര്യത്തിലൊക്കെ ഇതാണ് വന്നിരിക്കുന്നത്. 20 വീക്ക് എന്നുള്ളതാണ്. ബിക്കോസ് ചക്രവ്യൂഹത്തിനകത്തോട്ട് കയറാനായിട്ട് അഭിമന്യു അറിഞ്ഞു because at the time of 20th week of intrauterine life. That is based upon the theory that the labyrinth or the inner ear differentiates by around 20 week. Okay, it's completed by 16 to 25 weeks. So inner ear is or the labyrinth is the first special sense organ to differentiate in the body. And inner ear malformations the fetus can occur when the mother during pregnancy, especially if the mother is exposed to radiation, German measles, cytomegalovirus, and thalidomide. Okay. So most of the congenital anomalies of the inner ear can occur during first trimester of pregnancy. If the mother get all these in the first trimester of pregnancy, there is high chance of the child born with some congenital anomalies of the inner ear. Okay, so labyrinth is the first special sense organ to differentiate in the body, right? So we can go through some questions. Correction of a malformed pinna is done at what age? Autoplasty, age is anyone? Yeah. Okay, very good. 5 to 6 years. Then a coloral fistula is an anomaly of which arch? It is an anomaly of first arch because on the first pharyngeal cleft. Development of eustachian tube is from where? Eustachian tube along with the middle ear cleft is developing from the tubotympanic recess. So middle ear cleft എന്ന് പറയുന്നത് എന്തൊക്കെയാണ്? Eustachian middle ear, eustachian tube along with the mastoid cavity. So all these are developing, or the tympanic cleft or the middle ear cleft is developing from the tubotympanic recess. So eustachian tube and the middle ear developing from tubotympanic recess. Okay. Then what structures of the ear are at adult size at birth? So the middle ear, ossicle, and the inner ear are adult size at birth. Pinna is fully formed at birth, but it reaches adult size by 5 to 6 years of age. Okay. So middle ear along with the ossicles in the middle ear and the inner ear, it is at adult size at birth. All structures of ear except external auditory canal and mastoid process are fully formed at birth. Okay. And but only the middle ear, ossicle, and the inner ear reaches adult size at birth. That should be remembered. Okay. So middle ear, ossicle, and inner ear, they reaches adult size at birth, and all structures except external auditory canal and mastoid process are fully formed at birth. Right? Now, nerve supply. So some questions are asked in the nerve supply. Nerve supply of pinna. You have a medial surface and you have a lateral aspect. Medial aspect എന്ന് പറയുന്നത് നമ്മുടെ സ്കള്ളിനോട് ചേർന്നിരിക്കുന്ന ഭാഗം. Lateral aspect എന്ന് വെച്ച് കഴിഞ്ഞാൽ പുറത്തേക്ക് ഇരിക്കുന്ന ഭാഗം. അപ്പോൾ lateral aspectല് മെയിൻ സപ്ലൈ വരുന്നത് auriculotemporal, which is a branch of fifth nerve. Then lesser occipital on the medial aspect. And tragus mainly supplied by auriculotemporal. So tragus and also the upper part of the surface is my fifth nerve, that is auriculotemporal. Then a major part of skin of pinna is supplied by greater auricular nerve. Okay, so greater auricular, lesser occipital on the medial aspect, auriculotemporal on the lateral aspect along with the upper anterior. And ഈ കോങ്കയിലെ കുറച്ച് ഭാഗം auricular branch of vagus nerve. അതാണ് പിന്നേല് വരുന്നത്. And this is external auditory canal. And in the external auditory canal, this is anterior part. Anterior part is again by auriculotemporal. See, auriculotemporal. Here also the anterior part is on the പിന്നീട് anterior part auriculotemporal ആണ്. External auditory canal anterior part auriculotemporal ആണ്. It's a branch of 5th nerve. Then the floor is by the 10th nerve. So the auricular branch of vagus in the perana Arnold nerve. Okay, auricular branch of vagus nerve is called Arnold nerve. And you have noticed that when we clean the ear or when we take wax from the ear, sometimes the patient start cuff reflex. Therefore, നമ്മൾ വാക്സ് എടുക്കുന്ന സമയത്ത് തല കറങ്ങാം, there will be a patient can collapse, and also ചിലപ്പോൾ patient ചുമച്ചുകൊണ്ടിരിക്കും. അതിന് കാരണം that is mediated by the Arnold nerve, which is a branch of the auricular branch of vagus nerve. 10th ആണ് വരുന്നത്. And in the posterior part, little part is supplied by C3. That is why when the patient is having an cervical spondylitis can present as earache. And in the postero-superior part, is small sensory supply from the facial nerve. Nervous intermediates are it's a sensory supply of facial nerve is through the nervous intermediates. So in acoustic neuroma, some patients there can be a sensation, deficit sensation or hyperesthesia on the postero-superior part of the external auditory canal, and that is called the Hitzelberger sign. Okay, so Hitzelberger sign is there will be a sensation discomfort, or there will be an altered sensation on the postero-superior aspect of the external auditory canal, which is mediated through the nervous intermediates, that is a sensory branch of facial nerve, and that is called the Hitzelberger sign. And this is sometimes seen as one of the first symptom of an acoustic neuroma. Okay, so that is Hitzelberger sign. Then cuff reflex on ear cleaning is mediated by Arnold nerve, which is the auricular branch of vagus nerve. Okay. Then you can have on tympanic membrane, supply is mainly by the on the outer surface, it is from the auriculotemporal and auricular branch of vagus, and on the inner surface, that is towards the middle ear, it is from the tympanic plexus, because middle ear supply pradhanamaayittum tympanic plexus aanu through glossopharyngeal and also from the sympathetic. And on the outer surface, that is by the auriculotemporal and also the auricular branch of vagus nerve, which is called Arnold's nerve. And in malignancy base of tongue and tonsil, the patient can present as referred otalgia, and that is mediated through the auricular branch of glossopharyngeal. That is called the Jacobson's nerve. Okay, so the auricular branch of glossopharyngeal or 9th cranial nerve is called Jacobson's nerve, and the auricular branch of vagus nerve or the 10th cranial nerve is called the Arnold's nerve. So supraglottic malignancies of the base of tongue, and also tonsillitis, or in the malignancy of tonsil or any growth of tonsil, can present as otalgia, which is mediated through glossopharyngeal nerve, that is through the Jacobson's nerve. So this is one question. Tympanic membrane is supplied by following nerves except ഏതാണ് ഇത്രയും നമ്മൾ പറഞ്ഞതിനകത്ത് വന്നിരിക്കുന്നതാണത്. It is auriculotemporal is supplying, auriculotemporal is branch of 5th nerve, it's supplying it. Vagus nerve 10th, again supplying the tympanic membrane. Glossopharyngeal, that's the 9th nerve, again supplying the tympanic membrane on the inner surface, that is on the mucosal surface. And the answer is here is chordae tympani. Yes, because chordae tympani as such is not supplying the tympanic membrane, it is just passing through the it is passing through the layers of tympanic membrane on the middle ear area. So chordae tympani as such is, chordae tympani is a branch of which nerve? It is a branch of facial nerve, and it is not supplying the tympanic membrane. So the answer is chordae tympani. Now remember this colors of tympanic membrane, and in a set, sometime the color will be given as an image and questions will be there. So normally the tympanic membrane, it is the pearly white or grayish in color. That's the normal color of tympanic membrane. It's pearly white or grayish color. Glue ear or in a secretory otitis media, it will be more towards blue color. And also a waxy tympanic membrane, waxy tympanic membrane is very typical of blue ear or a secretory otitis media. Okay, so pearly white normal, bluish in a secretory otitis media, and red and congested with a cartwheel appearance, bulging tympanic membrane. See, red congested cartwheel appearance or bulging tympanic membrane is seen in an acute otitis media, and a flamingo pink color is seen in an active otosclerosis. Okay, so these colors, remember this, normal is pearly white, in bluish, acute otitis media, it is more of red color, and in flamingo pink in an active otosclerosis. Okay. Now, this I already explained about the middle ear. Development is from the middle ear cleft, that is from the tubotympanic recess. Mainly the first and partly from the second pharyngeal pouch. Okay, middle ear cleft. So, as a eustachian tube is part of the middle ear cleft. Middle ear cleft means middle ear cavity, eustachian tube, attic, and the mastodandrum. So, you can remember as middle ear eustachian tube and the mastodandrum forms the middle ear cleft, and all these are developing from the tubotympanic recess. And ossicle, there are three ossicles, malleus, incus, and stapes. So malleus and incus are developing from the Meckels. M ആണ് ഫസ്റ്റ് ആർച്ചിലെല്ലാം M ആണെന്ന് ഓർത്താൽ മതി. Mandible, maxilla, malleus, all are, and Meckel's cartilage, all are from the first arch. Okay, and in the stapes, the superstructure is from the second arch and the footplate is from the aortic capsule. Okay, so the malleus and incus from first arch, and in the stapes has got a superstructure and also it has got a footplate. Okay, so the superstructure is developing from the second arch and this footplate is developing from the aortic capsule. Okay, and another one is in the development comes a stapedial artery. So actually this stapedial artery has to it should not persist, or it should resolve in some stage of development. And if this stapedial artery is persisting, this is seen as a soft tissue mound over the stapes footplate. So stapedectomy is we are doing for otosclerosis, and in stapedectomy we are surgery where we are doing something over the footplate. So if this stapedial artery is persisting, it can cause an alarming bleeding during stapedectomy. Okay, stapedectomy is a surgery for otosclerosis, and this stapedial artery, if it is persisting, this can present as a soft tissue mound over the footplate of stapes, and this can lead to alarming bleeding during stapedectomy. Okay, so malleus and incus from the first arch, stapes, superstructure is from the second arch, and footplate is from the aortic capsule. That is the development of ossicles. Okay, so middle ear and middle ear cleft, tubotympanic recess, and the ossicles. Then, so anatomy is over. Just remember the pinna, then the external auditory canal is from the first pharyngeal cleft, then the middle ear cleft is from the tubotympanic recess, and malleus and incus from first arch, and stapes from second arch, and also from the aortic capsule. Then we can go through the anatomy very fast. So all these are different questions which are repeatedly asked. So in the middle ear anatomy, this is the cut section. The narrowest part of middle ear which is the narrowest part of middle ear. Middle ear can be divided into an epitympanum, a mesotympanum, and a hypotympanum. So this is tympanic membrane. So if you are drawing a line on one line over the superior aspect of pars tensa, and second line passing through the lower part, inferior aspect or lowermost part of the pars tensa, we can divide the middle ear into three areas. Above this line is epitympanum, and in between the two lines comes the mesotympanum, and below that is the hypotympanum. So of these, which is the narrowest part, narrowest part is the mesotympanum. Okay, that is 2 millimeters. So narrowest part of middle ear is mesotympanum. And another important, usually asked one is scutum. Okay, so this part is scutum. Scutum is a lateral attic wall. So erosion of the scutum is usually seen in attic polysteatoma. Okay, so in this part, this reddish red thing, usual site of attic polysteatoma, which is a Prusak space, and this attic polysteatoma, if there is an attic polysteatoma, in radiology, you can see an erosion of this lateral attic wall. And this lateral attic wall is otherwise called the scutum. So erosion of the scutum in radiology pointing towards an attic polysteatoma. Okay. And this attic polysteatoma, the common site of development of an attic polysteatoma is Prusak space. This area is a Prusak space. Between the neck of malleus and the lateral attic wall comes the Prusak space. So Prusak space is a common site of development of an attic polysteatoma, and its attic polysteatoma usually presenting as an erosion of the lateral attic wall. Lateral attic wall is otherwise called the scutum. So erosion of the lateral attic wall leading to attic polysteatoma. Okay, it's a point towards presence of an attic polysteatoma. Yes. Then another two terminologies you have to remember. One is a sinus tympani and another one is facial recess. Okay, sinus tympani is an area in the middle ear and another one is facial recess. So what are the importance of that? So most common site of a recurrent cholecystioma is sinus tympani. Recurrent cholecystioma means there is a cholecystioma. We have done a mastoid exploration of that area and we have completely removed the cholecystioma. Okay. And within a period of 6 months, this is again happening. We have completely removed it and then it is happening again. Then it is called a recurrent cholecystioma. But if we are not completely removing a disease and we are keeping something there without our knowledge or inadvertently, we are keeping something in that area, that is called a residual cholecystioma. This is random organ. Recurrent cholecystioma and residual cholecystioma. Recurrent is something, it will be removed completely and it is happening again. Residual is we are not removing anything, some part. Residual cholecystioma. So the most common site of recurrent cholecystioma is sinus tympani, and most common site of a residual cholecystioma is sinodural angle. Okay, sinodural angle. It is sinodural angle. So in the area in the mastoid between the sigmoid sinus and the dural plate is a sinodural angle. So most common site of residual cholecystioma is sinodural angle and recurrent cholecystioma is sinus tympani. And the importance of facial recess is that this is a route through which we are putting the electrodes of the cochlear implant into the middle ear. So for cochlear implantation, first we have to do a cortical mastoidectomy. And after that, we are doing a facial recess approach or a posterior tympanotomy. Tympanum means middle ear cleft. So into the tympanum, we are making an otomy posteriorly. So posteriorly, we are approaching into the middle ear and that is through the facial recess. Okay. So cochlear implantation comes the term facial recess, and recurrent cholecystioma sinus tympani and residual cholecystioma sinodural angle. Okay. So middle ear anatomy. Then coming to the different, you know that the middle ear is an like a 6-walled cavity. ഒരു എന്താണായിട്ട് യൂഷ്വലി പറയുന്നത് നമ്മൾ ഒരു തീപ്പെട്ടിക്കൂടിന്റെ 6 വാൾസ് ഉള്ള ഒരു തീപ്പെട്ടിക്കൂടായിട്ട് ആണ് കമ്പയർ ചെയ്യുന്നത്. So it has got a roof, it has got a floor, then there is an anterior wall, there is a posterior wall, there is a medial wall and the lateral wall. So lateral wall എന്ന് വെച്ച് കഴിഞ്ഞാൽ വെളിയിലോട്ട് ഇരിക്കുന്നത്. എന്താണ് അവിടെ വരുന്നത്? There is tympanic membrane in the lateral wall, isn't it? So laterally there is tympanic membrane and the medial wall there is promontory. And what is the roof? Roof is towards the brain. So in the roof, there comes the tegment plate and above that is the middle brain, that is the middle fossa. Okay. So tegment plate to the brain into the in the roof. Then the floor, that is the jugular bulb, and on the medial wall mainly comes the tendon. Anterior wall, there comes the tendon of tensor tympani muscle, and below that comes the eustachian tube. Okay. So roof is a tegment plate. Floor related to the jugular bulb. Anteriorly, there is above by the tendon of tensor tympani and below by the eustachian tube, and also anterior relation is the internal carotid artery. Okay. So anteriorly perforated by tendon of tensor tympani muscle and the eustachian tube, and another anterior relation is the internal carotid artery, and floor the jugular bulb, roof by tegment plate, and on the medial wall there is promontory, that's a bulge of the first turn of cochlea, then geniculate ganglion, and also the facial nerve is passing through that. After that, there is oval on the promontory. Superiorly, there is oval window or fenestra vestibulae. Below that is round window or fenestra cochleae. Then the hook-like processes cochleariformis. That is all in the medial wall. Okay, medial wall on a promontory, oval window, round window, processes cochleariformis. Then the geniculate ganglion, and also the tympanic part of facial nerve. Right? So roof by the tegment plate, separating it from the brain. Then on the floor, there is jugular bulb, and laterally there is tympanic membrane. Medially, there is promontory. Then comes the oval window, the round window. Then the processus cochleariformis. Process cochleariformis is a hook-like thing, which is related to the first turn of facial nerve. Okay. Then related is the geniculate ganglion. Then the horizontal part of facial nerve coming, and then on the second genu on the posterior wall, and then it forms its second part, or the vertical part. And the vertical part is coming and going out as the stylomastoid foramen. Then it is spreading as a pes anserinus over the parotid gland. Okay, salivary gland. So that is facial nerve. Then the posterior relation is your mastoid posteriorly. Okay. So ഈ പടം ഈ ഒരു ഡയഗ്രാം നിങ്ങൾ മനസ്സിൽ വെക്കണം, ബിക്കോസ് ഇതിൽ നിന്ന് തന്നെ കുറെ ക്വസ്റ്റ്യൻസ് ചോദിക്കാം. റിലേഷൻ ഓഫ് ദ eustachian tube, relation of the tensor tympani muscle both on the anterior wall, then relation of the internal carotid artery again anteriorly, the floor, the jugular bulb, then the round window and niche and the oval window both are on the medial wall. Okay, posteriorly there is mastoid, and through the posterior wall goes the vertical part of facial after the second genu. Okay, so facial nerve coming from the internal carotid, internal acoustic meatus, then through the canal of facial nerve, it is coming into the medial wall of middle ear. Then it is turning there, that is the first genu of facial nerve. Then it's going as a horizontal part. Then the second genu, and then the vertical part coming out through the stylomastoid foramen, and it is going through the parotid gland. So that is the root of facial nerve. So on the posteriorly, the relation of the middle ear is the mastoid, and the volume of middle ear and mastoid antrum is 2 ml. Okay. Regarding facial recess, we already told. That is, it is an area which is bounded medially by the facial nerve, laterally by the chordae tympani, and superiorly by the fossa incudis. Medially facial nerve, laterally chordae tympani, and superiorly fossa incudis. Through this we reaches into the middle ear, that I already told. It's a posterior tympanotomy, and this is the surgical approach for cochlear implantation. And this also you have to remember that sinus tympani is always medial to the facial nerve. Sinus tympani is medial to the facial nerve, and facial recess is lateral to the facial nerve. As undergraduates, it's a bit confusing to know this anatomy of middle ear. So just remember as such, because sinus tympani is medial to the facial nerve and facial recess is lateral to the facial nerve. Okay. And because sinus tympani, this relation is sometimes more asked as MCQs also. Sinus tympani is medial to the facial nerve. And what was the importance of sinus tympani? It is a common site of a recurrent cholesteatoma. Okay. What are the contents of middle ear? The contents of middle ear, one is air is there. Then there are three ossicles, that is malleus, ingus, and stapes. Then there are two muscles. What are the two muscles? One muscle, two muscle. What are they? Two muscle. One is, this one is tensor tympani. We already seen that the anterior, through the anterior wall, tensor tympani is coming, and then it is turning to the malleus to get attached to the malleus. So one is tensor tympani, which is supplied by the mandibular nerve, and another one is stapedius, which is supplied by facial nerve. And in facial palsy, you get hyperacusis and phonophobia. Okay, hyperacusis means small sound vibrations are heard as big sounds, and also phonophobia. So hyperacusis and phonophobia is seen in facial palsy because there is paralysis of the stapedius tendon. Okay, and another muscle is tensor tympani. So two muscles, one is tensor tympani and stapedius. And there are three nerves. One is tympanic plexus, which is seen over the promontory. Chordae tympani is going through the laterally, and also there is nerve to stapedius, which is supplied this is facial nerve. From the facial nerve goes to the stapedius tendon, goes nerve to stapedius, and this is chordae tympani. And on the promontory, you will get tympanic plexus also. Okay, tympanic plexus is mainly from the glossopharyngeal nerve and also sympathetic plexus. So middle ear contains three ossicles, malleus, ingus, and stapes, two muscle, tensor tympani and stapedius, and three nerves. Air, air is also present, because if there is no air, this movement of these muscles and ossicles will not happen. Okay. And one word about Jacobson's nerve. That is, it's an auricular branch of glossopharyngeal nerve. And this Jacobson's nerve supplies the middle ear and the mastoid air cell. And this is supplies secretomotor fibers to the parotid gland. And sectioning of the Jacobson's nerve is done in gestatory sweating. Gestatory sweating is something related to the parotid. So what we do is, or the in Frey syndrome, FREY, Frey syndrome, we do the sectioning of the Jacobson's nerve. And also this sensory nerve supply of the middle ear comes from the glossopharyngeal nerve. So auricular branch of glossopharyngeal is the Jacobson's nerve. Okay. So remember, it is the nerve. This Jacobson's nerve sectioning is done in gestatory sweating in Frey syndrome. And regarding ear ossicle, ear ossicles and the middle ear is adult size at birth. That is one thing. And another one is, two joints are there. One is an ingudo-malleus joint from malleus and incus. That is a saddle joint. And the between the incus and the stapes, it is a ball and socket joint. Okay. So between this incus and stapes, it's a ball and socket joint, and incus and malleus is a saddle joint. And in a cholesteatoma, the most common site of necrosis is the long process of incus. Okay, because this long process of incus, there is an end arterial blood supply. Okay, so once it is cut off, there is chance of necrosis. So remember the two joint. One is a saddle joint, and another one is a ball and socket joint. And most common site of necrosis is a long process of incus. And stapes is the smallest bone in the body. And most common congenital anomaly in the middle ear is a fixity of foot plate of stapes. Okay. So this there are something which are more common with stapes. One is smallest bone. Stapes in a peculiarity in the smallest bone in the body. Then most common congenital anomaly of the middle ear is fixity of foot plate of stapes, and inguinostapedial joint is a ball and socket joint. And there are two terminology which are the VORP and FMT. And then the VORP and FMT are something related to vibrant sound bridge, which is an implantable hearing devices, and that's also important. Implantable hearing devices. So I'll tell the implantable hearing devices. One is a vibrant sound bridge. Second one is bone anchored hearing aid. Then there is a cochlear implant. Then another one is an auditory brainstem implant and also auditory midbrain implant. Okay. ഈ അഞ്ചെണ്ണം കുറെ ക്വസ്റ്റ്യൻസ് ഇതിന്ന് ചോദിക്കാറുണ്ട്. So vibrant sound bridge എന്താണ്? It's a partly implantable hearing system of adult. This is vibrant sound bridge. See, there is for all these implantable hearing aid, there will be an external part and there will be an internal part. For the vibrant sound bridge also, there is an external part, that's an audio processor, and there is an internal part. Okay. And this is the internal part. Internal part in the vibrating ossicular processes, and the tip of this vibrating ossicular processes is called the floating mass transducer. Okay. And that is attached to the incus. Okay. That is attached to the incus also. So indications are mild to severe sensorineural hearing loss and also for conductive and mixed hearing loss. And for vibrant sound bridge, we keep the for mild to severe sensorineural hearing loss. And in profound hearing loss, sensorineural hearing loss, we usually keep the cochlear implants. Okay. So indication for a vibrant sound bridge is mild to severe sensorineural hearing loss and also conductive and mixed hearing loss. And this is implanted in the middle ear and mechanically vibrates the middle ear structures. Okay. So vibrant sound bridge is implanted in the middle ear, and that mechanically this vibration of this FMT, that's floating mass transducer. So padam ningal orthirunna madi. So this vibrant sound bridge has got an audio processor externally, and it has got an internal part which is called the VORP or vibrating ossicular processor. Think it as the internal part is vibrating the ossicles. Which ossicle? Mainly the incus. Okay. And that is attached to the incus, and that part, attached part, is called the floating mass transducer or the FMT. So that is vibrant sound bridge, and the indications are mild sensorineural hearing loss, conductive hearing loss, and also mixed, both conductive and sensory. Okay. And another one is BAHA, bone anchored hearing aid. Bone anchored hearing aid is again bone anchored hearing has got a processor, and there is an abutment, and this is attached to the cortical skull bone through a technique called osseointegration. And the indication, these are the indications. See, in this child, you can see that there is no external auditory canal. Okay, there is this external auditory canal, there can be atresia, or this pinna is not there, it is completely absent. So pinna is not there, or there is the external auditory canal is not there, or external auditory canal atresia, or external auditory canal stenosis, or the ear is completely always discharging, so that you cannot keep a hearing aid into the external auditory canal because it is discharging. അതിന് എപ്പോഴും ഡിസ്ചാർജ് വന്നുകൊണ്ടിരിക്കുകയാണ്. അപ്പൊ എന്ത് പറ്റും? ഹിയറിംഗ് എയ്ഡ് വെക്കുമ്പോൾ തന്നെ അത് കേടായി പോകും. അപ്പൊ അങ്ങനത്തെ കണ്ടീഷൻസിൽ we have to do some alternative techniques. External auditory canal ഇവിടെ ഇല്ല. അപ്പൊ അതുകൊണ്ട് എന്ത് ചെയ്യുന്നു? Completely we are putting it into the bone. So bone anchored hearing aid. എന്താണ് ചെയ്യുന്നത്? ഈ ഒരു കോർട്ടിക്കൽ ബോണിനകത്തോട്ട് നമ്മളൊരു അബട്ട്മെന്റ് വെച്ചിട്ട് അതിനൊരു ഓസിയോ ഇന്റഗ്രേഷൻ എന്നുള്ള ടെക്നിക്ക് വഴി അതിനകത്തോട്ട് ബോൺ ആങ്കേർഡ് ഹിയറിംഗ് എയ്ഡ് വെക്കുകയാണ്. So these are the indication. That is, just remember that external auditory canal is not working properly, or external auditory canal is not there, or external auditory canal stenosis, or there is this completely always discharge from the external auditory canal. So we have to look for some alternative methods so that this bone anchored hearing aid is fixed into the cortical bone. Okay. And this is also, these are the indication. This can also be done in case of unilateral severe sensorineural hearing loss. Unilateral severe sensorineural hearing loss. Okay. So these are the indications of bone-anchored hearing aid. See, this is usually asked question. All the following are true about bone-anchored hearing aid, except Dana. It has surgically implantable titanium fixture. It's correct. It transmits the sound directly to the cochlea through the bone conduction using a principle of osseointegration. Again, correct. It is indicated in patient with external aortic canal atresia. We already discussed that. It is not indicated in patient with discharging air with hearing loss. That's correct, no? It is not indicated in the correct. So because it is indicated in patient with discharging air, I already told that there is some problem with external aortic canal. ഒന്നുകിൽ external aortic canal ഇല്ല, atresia ആണ്, or external aortic canal stenosis ആണ്, അല്ലെങ്കിൽ external aortic canal എപ്പോഴും discharge വന്നുകൊണ്ടിരിക്കുന്നു, so that hearing aid വെക്കാൻ പറ്റുന്നില്ല, hearing aid വെക്കുമ്പോൾ തന്നെ അത് ഫ്യൂസ് ആയി പോകും. അങ്ങനെയുള്ളതിലാണ് നമ്മൾ bone anchored hearing aid വെക്കുന്നത്. So the answer here is question is all the following are true except none. False ആണ് ചോദിച്ചിരിക്കുന്നത്. So it is not indicated in patient discharging with hearing loss is false. Another frequently asked question is principle of Baha. Principle of Baha എന്ന് വെച്ച് കഴിഞ്ഞാൽ CROS ആണ്. അത് contralateral routing of signals ആണ്. അതായത് it is keeping on one side. So through the bone vibration, from the other side also we can hear the signal. That is contralateral routing of signal is the principle of bone anchored hearing. It's CROS. This is also usually asked question. Okay, CROS is the answer. Contralateral routing of signal. So that is regarding bone anchored hearing aid. Another implantable hearing devices is cochlear implant. Okay, cochlear implant. Cochlear implant also got an external part. It has also got an internal part. Okay, so external part ഇത്രയും കാര്യങ്ങളാണ്. എന്തൊക്കെയാണ്? ഒരു transmitter ഉണ്ട്. എന്തിനു വേണ്ടിയാണ് ഈ transmitter? അതായത് നമ്മൾ ആദ്യം through the postoral approach, we put the incision and we do a cortical mastoidectomy. And ഈ cortical mastoidectomy ചെയ്തതിന് ശേഷം we do a facial recess approach or a posterior tympanotomy. Okay. And in ഈ ഒരു cortical mastoidectomy ചെയ്ത അതിൻ്റെ ഉള്ളിലാണ് ഇതിന്റെ internal part വെക്കുന്നത്. അപ്പം ഈ ഒരു part വെക്കുന്നത്. Okay. So ഇതിന്റെ വെളിയിൽ ഒരു transmitter ഉണ്ട്. Then there is behind the ear there is a battery and also a speech processor, and microphone is kept into the external aortic canal. Okay, so external part has got a transmitter, it has got a battery, it has got a microphone and also a speech processor, and the internal part the main electrodes are. These electrodes are gone. We are putting the electrode through the facial recess or through the posterior tympanotomy. The electrodes are coming into the middle ear. Through the it is going into the cochlea. Cochlea എങ്ങനെയാണ് പോകുന്നത്? Round window അകത്തൂടെയാണ് പോകുന്നത്. So we are doing a cortical mastoidectomy, and from the cortical mastoidectomy we are reaching into the middle ear through the facial recess approach, and in the middle ear we are looking into the round window. See, through the round window we are putting it into the scala tympani. Okay, so remember the parts of cochlear implant. And see, after doing the cortical mastoidectomy, this is the facial recess, and through the facial recess we can very clearly see the round window, and through the round window we are inserting the electrodes into the cochlea. That is evideyana cochlea scala tympani ilana. Cochlea has got scala media, it is called scala tympani, and also scala vestibulae. Okay, so scala vestibulae, scala media and scala tympani. അപ്പം ഇതിനകത്ത് കോക്ലിയർ ഇംപ്ലാന്റിന്റെ ഇലക്ട്രോഡ്സ് എടുക്കുന്നത് സ്കേല ടിംപാനിയിലാണ്. ആൻഡ് ഏത് കൂടെയാണ്? ത്രൂ ദ ഫേഷ്യൽ റിസസ്, ത്രൂ ദ റൗണ്ട് വിൻഡോ നിഷ്. ഓക്കെ, സോ ഫസ്റ്റ് വി ആർ doing an mastoid exploration. After that the facial recess is opened, and through the facial recess we are putting the electrodes of cochlear implant into the round window niche, through the round window going into the scala tympani. So that is how we do a cochlear implantation. അപ്പോൾ ഇതെല്ലാം ഇമ്പോർട്ടൻ്റ് ആണ്. Cortical mastoidectomy, facial recess, round window, scala tympani. Okay. And The principle of Bach എന്താണ് പറഞ്ഞത്? Bone anchored hearing aidന്റെ principle CROS ആയിരുന്നു, contralateral routing of signals ആയിരുന്നു. ഇതിന്റെ എന്താണ് cochlear implant? Through the electrodes are going. See, the electrodes are going and it is directly stimulating the cochlear nerve endings. Okay, so that is the principle of cochlear implant, direct electrical stimulation of the cochlear nerve ending. So what should be the prerequisite of a cochlear implant surgery? Normal eighth nerve. If the eighth nerve is not functioning normally, if there is no eighth nerve, you cannot do a cochlear implant because the cochlear implant is working through direct electrical stimulation of the cochlear nerve ending. Okay. Normal eighth nerve is a prerequisite of cochlear implant surgery. And another question usually asked is, can you do cochlear implant in cochlear dysplasia? Cochlear dysplasia example ആണ് Mondini dysplasia. Usually there is 2.25 turns ആണ്. അത് ചിലപ്പം അതിനേക്കാളും കുറഞ്ഞിട്ട് ഒരു ടേൺ ഒക്കെ only 1.5 turn. If there is only 1.5 turn, it is called the Mondini malformation. Okay. അപ്പം usually ഉള്ള 2.25 turn 1.5 turn ആയി മാറുകയാണെങ്കിൽ it is called Mondini dysplasia. So can you do cochlear implant in a Mondini dysplasia? The answer is yes. ഇതിൽ എന്താ ചോദിച്ചിരിക്കുന്നത്? Cochlear dysplasia ഒരു contraindication ആണോ എന്നാണ് question. No, you can do cochlear implantation in cochlear dysplasia or Mondini deformity. Okay, you can do. It is not a contraindication. Okay, and the indication of a cochlear implant is bilateral profound sensory neural hearing loss or a total deaf child. You can do the indication of cochlear implant is a total deaf child. Okay. And there are multi-channel implant and single channel implant. എന്ന് വെച്ചാൽ നേരത്തെ നമ്മളൊരു ഇലക്ട്രിക് അത് കാണിച്ചല്ലോ, ഇലക്ട്രോഡ്സ്. അതിന് മൾട്ടി ചാനൽസും ഉണ്ട്, അല്ലെങ്കിൽ ഒരു സിംഗിൾ ചാനലിൽ കൂടെ പോകുന്നതും. അപ്പൊ സിംഗിൾ ചാനലിൽ നമ്മളിപ്പോൾ ചെയ്യുന്നില്ല, ഇന്ത്യയിൽ ഇപ്പൊ അധികം ചെയ്യുന്നേ ഇല്ല. മൾട്ടി ചാനൽ ഇംപ്ലാന്റ്സ് ആണ് നല്ലത്. സോ മൾട്ടി ചാനൽ ഇംപ്ലാന്റ്സ് ആർ ബെറ്റർ ദാൻ സിംഗിൾ ചാനൽ ബിക്കോസ് ദ ഫ്ലോറിൽ എപ്പോഴും കോക്ലിയയുടെ ഫ്ലോറിനകത്ത് towards the base and there is towards apex signals are there. So multi-channel signals you get multiple signals through a multi-channel implant. So multi-channel implant is better than single channel implant. ഈ പോസ്റ്റ് ലിംഗ്വൽ ഡെഫ് ചൈൽഡ് എന്ന് വെച്ച് കഴിഞ്ഞാൽ എന്താണ്? അതായത് കുട്ടി സ്പീച്ച് ഡെവലപ്പ് ചെയ്യുന്ന സമയം വരെയും ഹിയറിംഗ് നോർമൽ ആയിരുന്നു. അതിനുശേഷം ഡ്യൂ ടു സം viral infections or meningitis or something, after development of speech, the hearing has gone. It is called post-lingual. Pre-lingual എന്ന് വെച്ച് കഴിഞ്ഞാൽ സ്പീച്ച് വരുന്നതിന് മുന്നേ പോകുന്നതാണ്. അപ്പം അവർക്ക് അവരുടെ ബ്രെയിനകത്ത് ഒരു സിഗ്നലേ വന്നിട്ടില്ല. So post-lingual deaf is always showing better result than a pre-lingual deaf. So multi-channel implant, post-lingual deaf. Okay. So indication of cochlear implant is bilateral profound sensory neural hearing loss. ഇതൊരു കോമൺ സെൻസ് ആണ്. മൾട്ടി-ചാനൽ ഇംപ്ലാന്റ് കുറച്ചുകൂടി നല്ലതാണ്. പോസ്റ്റ്-ലിംഗ്വൽ ഡെഫ്നെസ് കുറച്ചുകൂടി ബെറ്റർ റിസൾട്ട് ആയിരിക്കും. ആൻഡ് how can you approach the cochlea? As I already told, one is through a facial recess approach, that is posterior tympanotomy. ഇപ്പൊ ഒരു പുതിയ ടെക്നിക്ക് വന്നിട്ടുള്ളതാണ്. ഈ നമുക്ക് കനാലിൽ കൂടെ തന്നെ കനാലിൽ കൂടെ തന്നെ വേരിയ ടെക്നിക് എന്ന് പറയും. ഇപ്പൊ കനാലിൽ കൂടെ തന്നെ മാസ്റ്റോഡ് എക്സ്പ്ലോറേഷൻ ചെയ്യാതെ തന്നെ കനാലിൽ കൂടെ നേരിട്ട് മിഡിൽ ഇയറിലോട്ട് ടിംപാനി മെമ്പറൈൻ ഫ്ലാപ്പ് പൊക്കിയിട്ട് നേരിട്ട് മിഡിൽ ഇയറിലേക്ക് പോകുന്നതാണ് വേരിയ ടെക്നിക്. സോ ദർ ആർ two techniques or two approaches for cochlear implantation. One is facial recess approach or posterior tympanotomy approach. Another one is varia technique or transcanal approach. So ഇത്രയും കാര്യങ്ങൾ cochlear implant പറ്റി അറിയണം. There is an external part, there is an internal part. Then we are putting it through the round window into the scala tympani. Principle is direct electrical stimulation of cochlear nerve ending. There should be a normal eighth nerve. Cochlear dysplasia is not a contraindication of cochlear implantation. It's usually done in bilateral profound sensory neural hearing loss. Okay. ഇതെല്ലാം റിപ്പീറ്റഡ് ആയിട്ട് ചോദിച്ചിട്ടുണ്ട്. And another one. See, for cochlear implantation, there should be a normal eighth nerve. If normal eighth nerve is not there, then the implant of choice is auditory brainstem implant. Okay. Because usually in bilateral eighth nerve damage occurs in case of an acoustic neuroma surgery, NF2, neurofibroma type 2, Okay, so in that, after surgery, usually there is nerve damage will be there. So in that cases, we are putting a brainstem implant. Where are we putting the brainstem implant? See, in this, the receiver and the kuda poi cochlearikku പോകുന്നതിന് പകരം നമ്മൾ നേരിട്ട് എങ്ങോട്ട് പോകുന്നു brainstemലാണ് lateral recess of fourth ventricle. Okay, fourth ventricle ആണ് lateral recess of fourth ventricle ആണ് brainstem implant വെക്കുന്നത്. So there is no eighth nerve, bilaterally eighth nerve has been damaged. Indication is after NF2, after acoustic neuroma surgery, and we are putting the brainstem implant in the lateral recess of fourth ventricle. Okay, lateral recess of fourth ventricle. So if there is nerve damage, the choice is auditory brainstem implant. So most appropriate treatment for rehabilitation of a patient, first bilateral profound deafness following surgery for bilateral acoustic neuroma. എന്താണ്? It is not bilateral high-power digital aid. It is not bilateral cochlear implant. It's not unilateral cochlear implant. So it's a definite indication for a brainstem implant. Okay. Here there is bilateral profound deafness following surgery for bilateral acoustic neuroma. That means the eighth nerve damage is already there. So the only indication we can do a brainstem implant. Then child age 3 years presenting with severe sensory neural hearing loss, prescribed hearing aid, but showed no improvement. Severe sensory neural, see, severe sensory neural hearing loss, not responding to hearing aids. The next line of management, it is cochlear implant. And എന്തെങ്കിലും സംശയം ഉണ്ടോ അതിനകത്ത്? See, think that we are all in the same room. There is no other option. നമ്മൾ എല്ലാം ഒരു റൂമിനകത്ത് ചെയ്യുന്ന പോലെ അതിനകത്തോട്ട് ഇൻവോൾവ് ആവും. Okay. So fenestration surgery and stapes mobilization we are doing in otosclerosis. Okay. For conductive hearing loss. Fenestration surgery and stapes mainly for otosclerosis. And cochlear implant is in children with severe sensory neural hearing loss. There is no role of conservative measures. Okay. Right. Then in cochlear implant, the electrode most commonly placed at എവിടെയാണ് വെക്കുന്നത്? In cochlear implant, where are keeping the electrodes? നമ്മൾ ഇപ്പൊ തന്നെ ഡിസ്കസ് ചെയ്തതാണ്. അല്ല എങ്ങനെ റൗണ്ട് വിൻഡോ വരും? അത് നമുക്കൊക്കെ വരുന്ന ഒരു കുഴപ്പമാണ്. Where we are putting the electrodes, we are putting the electrodes through the round window into cochlea, അല്ലേ? അങ്ങനെയല്ലേ വരുന്നത്? കോക്ലിയയിലേക്കല്ലേ നമ്മൾ വെക്കുന്നത്? We are putting into the cochlea. Is it so? This should not go wrong, because we are putting the electrodes through the round window at cochlea, അല്ലേ? Scalar tympani of the cochlea ആണ്. അപ്പം പ്ലേസ് അറ്റ് എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ നമ്മൾ അവിടെ മാത്രം. അപ്പൊ അതങ്ങനെയല്ല. റൗണ്ട് വിൻഡോ ഒരു വിൻഡോ ആണ്. ആ വിൻഡോ കൂടെ നമ്മൾ കോക്ലിയ എന്ന് പറയുന്ന മുറിയിലോട്ട് ഒരു റൂമിലേക്ക് കിടക്കുന്ന പോലെ ആലോചിച്ചാൽ മതി. സോ ഇംപ്ലാന്റിനെ നമ്മൾ റൗണ്ട് വിൻഡോയുടെ അകത്തൂടെ കോക്ലിയയിലേക്ക് വെക്കുന്നു. സോ ഇറ്റ് ഈസ് കോമൺലി പ്ലേസ്ഡ് അറ്റ് ദ കോക്ലിയ, isn't it? So and the channel is through the round window. Round window കോക്ലിയയുടെ എവിടെയാണ്? Into the scalar tympani. Okay. So it is most commonly placed at cochlea. See, ഒരു വേർഡ് അറ്റ് എന്നാണ്. ത്രൂ എന്നാണെന്നുണ്ടെങ്കിൽ നമുക്ക് റൗണ്ട് വിൻഡോ എഴുതായിരുന്നു. സി അറ്റ് ആയതുകൊണ്ട് ഇറ്റ് ഇസ് കോക്ലിയ. സോ ഇങ്ങനത്തെ ഓരോ വാക്കുകളും വളരെയധികം ശ്രദ്ധിക്കണം. കാരണം നന്നായിട്ട് അറിയുന്ന കാര്യങ്ങൾ തെറ്റിക്കുന്നത് നല്ലതല്ല. സോ റീഡ് ദ ക്വസ്റ്റ്യൻസ് thoroughly, then only try to answer. ഇങ്ങനത്തെ എന്തെങ്കിലുമൊക്കെ ക്ലിക്ക് എപ്പോഴും അവര് വെക്കും ഈ ക്വസ്റ്റ്യൻ സെറ്റ് ചെയ്യുന്നവര്. അപ്പൊ അത് ശ്രദ്ധിക്കണം. Then another one is auditory brainstem implant. That is, if there is nerve damage, we go for a auditory a brainstem implant. And if the nucleus is damaged, then the other alternative is auditory midbrain implant. Okay, so central auditory implant, nerve deafness due to damage to the auditory nerve, that is the cochlear nucleus is damaged. In that case, we put the implant into the midbrain. Okay, so that is auditory midbrain implant. ഇതെല്ലാം കൂടി കൺസൈസ് ആയിട്ടുള്ള ഒരു picture ആണ്. So auditory in cochlear implant, we put the electrodes are placed into the cochlea. Cochlear implant into the cochlea. auditory brainstem implant, we are keeping into the lateral recess of fourth ventricle. Lateral recess of fourth ventricle. And auditory midbrain implant, we are putting into the midbrain. Okay. So, this is questions pradikshikam. Right. And one word of mastoid antrum and air cell. You know that antrum is this one antrum, mastoid antrum is the most constant air cell and first cell to develop inside the mastoid. Okay. And adult thickness, the mastoid is not fully formed at birth. It just reaches adult thickness by 15 millimeter and it reaches the full thickness by adult. And that is the difference between post-oral incision in other post-orally the William Wild's incision. In children, we put it more horizontally because this mastoid process or the lateral wall is not fully formed. So there is chance of damage to the facial. That's pediatric post-oral incision horizontal. That's the reason. Newborn thickness and adult thickness are different. Mastoid process absent at birth. It grow at a rate of 1 millimeter per year and it reaches adult size by 15 years. Okay. That's 15 year adult thickness 15 millimeter. 1 millimeter per year developing. Almost full thickness. And another important thing is Doralow's canal. Doralow's canal is space between the petrous apex and the supralateral portion of the clivus. So, this is important. Petrosphenoidal ligament of Gruber is boundary. Okay. And abducen now, inferior petrosal sinus and the dorsal meningeal artery. This is okay. So that this one is this boundary, this petrosphenoidal ligament of Gruber and the contents are important. Okay. Lateral rectus palsy inferior petrosal sinus are another content and dorsal meningeal artery. So that is important. Most congenital anomalies occur during this. Already we have told regarding this because most of the congenital anomaly occur during first trimester. Mondini malformation we already described. That is normal cochlea has got a 2/3/4 turn. When it is 1.5 turn, it becomes Mondini. And another one is Michael. Michael aplasia is total agenesis of labyrinth. There is no nerve is not there. So it is an indication for a brainstem implantation. So Michael, Mondini, in Mondini you can put cochlear implant, but in Michael aplasia, when there is total agenesis, it is an indication for a brainstem implant. Okay. And when it is membranous labyrinth agenesis, it becomes a Bing Zimmerman. And the commonest genital defect of inner ear causing deafness is cochlear saccular dysplasia or a Sheeby dysplasia. This is important. All are true of Mondini malformation of the inner ear except the middle ear artery. You know that Mondini malformation is the cochlea has got 1.5 turns. So cochlea normal in size but lack bony partition between the coil, that is true. Vestibule is dilated, true. Vestibular aqueduct is dilated, that is also true. But middle ear artery may not be. Okay, so Mondini is something related to the inner ear. So cochlea, the size is normal, but partition, that is instead of the 2/3/4 turn, the partition is absent. So its whole thing become 1.5 turns. And there is dilatation of the vestibule as well as the vestibular aqueduct. So middle ear atretic will not happen in case of Mondini malformation. And regarding inner ear, bony labyrinth present in the petrous part of, this is petrous part, so in the petrous part of temporal bone. And actually don't think as this petrous part of bony labyrinth is the strongest bone, and it's not the strongest bone, it's a cartilaginous bone. That's why MCQ bony labyrinth is the strongest bone, it's a cartilaginous bone. And cochlea coil is already we know it is coiled around the central modulus. So a screw poleana. That's central modulus and it is coming around 30 millimeters. and also semicircular canal, ambulated end, and also there is non-ambulated end. Etra semicircular canal in the moonanana, superior, posterior, and horizontal or lateral. So each one has got an ambulated end and non-ambulated end. The non-ambulated end of the superior and posterior joined together to form the crest commune. And what is arcuate eminence? It is projection of the superior semicircular canal on the floor of middle cranial fossa. Okay, arcuate eminence. And this is stimulated by rotation, and this will usually sense the angular movement. Very importance of Wanda. And this is important. This diagram is important. You know that movement of the stapes. Where is stapes? This is stapes. So movement of the stapes will cause scala vestibulae to vibrate. Okay. So this is scala vestibulae. And scala tympani is round window. So through the round window, we already discussed that in cochlear implant, the electrodes are placed through the round window. And through the round window membrane, it is going into the scala tympani. Okay, so round window membrane, scala tympani. Stape is scala vestibulae. Okay. And inner ear is supplied by the labyrinthine artery, which is a branch of anterior inferior cerebellar artery. Okay. And this scala vestibulae and scala tympani, there is perilymph, and in the scala media, there is endolymph. And this endolymph is rich in potassium. Okay. And also, this is uniting with the CSF through aqueduct of cochlea. So this can act as a channel of infection. Okay. So this can act as a channel of infection from the scala tympani or to and fro. Okay. So in case of meningitis, the CSF infection can come into the cochlea. That is why in child suffering from meningitis, there is chance of a sensory neural hearing loss. So infection is passing through the aqueduct of cochlea into the cochlea. Okay. Endolymphatic potential is again 80 millivolts. Okay, plus 80 millivolts. And this, what is this? Stria vascularis, dark vestibular cell, planum semilunatum. They are producing the endolymph. In the cochlea, the endolymph is produced by stria vascularis. In the utriculae saccule, the endolymph is produced by dark vestibular cells. And in the semicircular canals, the endolymph is produced by planum semilunatum. Which part, which of the following is producing endolymph in cochlea? It is stria vascularis. In case of utriculae saccule, it is dark vestibular cells, and in case of the semicircular canal, it is planum semilunatum. And just remember, this we full explain just remember the concise cochlea is mainly something sense organ of hearing. Okay. And this utricle saccule and semicircular canal, and they are the organs of balance. So in the cochlea, you know that there is cochlear duct. There are inner hair cells and outer hair cells, and they are concerned with hearing. And in the utricle and saccule, you get the macula, where there is otoconia. And in the ambulated end of semicircular canal, you get the cupula. Okay. So in the cochlea, that is cochlear duct. In the utricle and saccule, it is macula. And the ambulated end of semicircular canal is a cupula. Okay. So in BPPV, that is benign paroxysmal positional vertigo, this otoconia of the macula will fall down from the utricle into the posterior semicircular canal. Okay. അതായത് ഈ യൂട്രിക്കിളിനകത്തുള്ള മാക്യുലയിലാണ് ഓട്ടോകോണിയ. ഓട്ടോകോണിയ means some particles, calcium carbonate particles. Normally, they are supposed to sit in the utricle and saccule, but in some cases, due to so many reasons, this otoconia or the calcium carbonate crystals will fall from the utricle into the posterior ambulated end of the posterior semicircular canal. In that case, there is this vertigo will happen, and that is called the benign paroxysmal positional vertigo. Okay. So that is canal lithiasis or cupulolithiasis. That is BPPV is again an topic of interest of MCQs. And this low frequency sounds are towards the basal third of the cochlea, and the high frequency sounds are towards the apex. Okay, that's also important. And semicircular canals are concerned with the angular rotation, and utricle and saccule are with the linear rotation. Okay, linear rotation of utricle and saccule with linear rotation and angular rotation. അതായത് നമ്മൾ ജൈന്റ് വീലിലൊക്കെ കറങ്ങി തിരിയുന്നത് ഇപ്പോൾ അവിടുത്തെ ഒരു റൊട്ടേഷൻ വരുന്നത് സെമിസർക്കുലർ കനാൽസ് ആണ്. And the linear acceleration and deceleration is more concerned with utricle and saccule. You can think of the semicircular canal ഒരു ആംഗുലർ ആയിട്ടാണ് ഇരിക്കുന്നത്. അപ്പൊ അതുപോലെ തന്നെയാണ് അതിന്റെ റൊട്ടേഷൻ വരുന്നത്. അങ്ങനെ ആലോചിച്ചാൽ മതി. Endolymphatic duct is mainly concerned with the reabsorption of endolymph. Okay, so endolymphatic hydrops occurs in Meniere's disease. So endolymph in the production അല്ലെങ്കിൽ reabsorption difficulties വരുന്ന ഒരു condition ആണ് Meniere's disease. It is mainly controlled by the endolymphatic duct. And in higher auditory pathway, this again you can expect questions. So what is the this echolema, that is E for eighth nerve. From eighth nerve, it is going into the cochlear nucleus, and from there to the olivary complex, superior olivary complex. Then L is for lateral lemniscus, I for inferior colliculus, then medial geniculate body, and auditory cortex. Auditory cortex superior temporal gyrus. So this is a mnemonic for auditory pathway. Okay, eighth nerve, cochlear nucleus, olivary complex, lateral lemniscus, inferior colliculus, medial geniculate body, and auditory cortex. Okay. Echolema. Higher auditory center sound localization. Appreciation of sound is occurring in the transverse temporal gyrus. That is also important. Localization is in the auditory center, and appreciation of sound is in the transverse temporal gyrus. So, this confusion varanda. And another thing you have to remember is internal auditory canal. Internal auditory canal is around a 1 centimeter size channel. And in that, there is one Bill's bar which divides it into, first one is falciform crest. See, this is falciform crest, dividing this internal auditory canal into an upper part and lower part. And this is a Bill's bar that is happening only in the upper part. Okay, so this is anteriorly, there is facial nerve. 7up എന്നാണ് നമ്മൾ ആലോചിക്കുന്നത്. അപ്പോൾ 7up എന്ന് പറയുമ്പോൾ facial nerve upside, upper, anterior, superior പാർട്ടിലാണ്. Along with it, there is nervus intermedius or nerve of Brisberg. We talked about this, that is a Hitzelberger sign. Okay, and then cock down, cochlear nerve is on the lower part anteriorly, and posteriorly lower is the inferior vestibular nerve and also superior vestibular nerve in the upper part. So facial nerve on the upper side and cochlear nerve on the lower side. This is inferior. This is internal acoustic meatus. Okay. So internal acoustic meatus, remember the Bill's bar, falciform crest, and also the singular nerve of the inferior vestibular nerve. We supply the posterior semicircular canal. So in case of intractable vertigo affecting the posterior semicircular canal, we do a singulectomy, that is sectioning of the singular nerve, because singular nerve supplies the posterior semicircular canal. Okay. A person presented to OPD with complaints of rotatory vertigo and nausea in the morning and change in the position of head. What is your diagnosis? Rotatory vertigo, nausea with change in position. It is BPPV, benign paroxysmal positional vertigo. Next is a 28-year-old female presented with history of bilateral hearing loss and tinnitus. She can hear better in noisy environment. That is called paracusis willici. This may not be there. Sometimes they will tell us paracusis willici is present. That is why I put the word paracusis willici. Paracusis willici in the patient can hear better in noisy environment. That is, the paracusis willici in the clue that is pointing towards autosclerosis. Paracusis willici happen in autosclerosis. Examination showed an intact eardrum bilaterally. Rini test is negative bilaterally. Rini negative means there is conductive hearing loss, isn't it? Conductive hearing loss ilana Rini negative avunathu. Rini positive normal varam, sensory neural hearing loss varam. Okay. Pureton audiogram is given below. What is the most probable diagnosis? Pureton audiogram endha kanikkunne? There is a airborne gap along with the dip of bone conduction at 2K. That what is it called? It is called the dip of bone conduction at 2K is called Carhart's notch. So Carhart's notch happen in case of otosclerosis, and there is conductive hearing loss happen in case of otosclerosis. So stapedial otosclerosis is conductive hearing loss. If it is cochlear otosclerosis, the hearing loss will be sensory neural. Okay, there are two types of otosclerosis. The most commonly conductive hearing loss with the classical Carhart's notch happen in case of stapedial otosclerosis. In Meniere's disease, you get a sensory neural hearing loss. Again, in endolymphatic fistula, you get a sensory neural hearing loss. In vestibular schwannoma also, you get a sensory neural hearing loss. Okay, so the answer is stapedial otosclerosis. There is no confusion in that. Paracusis villi pointing towards an otosclerosis. This conductive hearing loss with the Carhart's notch pointing towards the stapedial otosclerosis. അങ്ങനത്തെ ഒന്നും ഒരു കൺഫ്യൂഷനും ആവശ്യമില്ല. It is stapedial otosclerosis. Calorie test was done on right side with cold water. Eyes moved to the opposite side. Which of the following corresponds to correct interpretation of nystagmus? See, എന്താണ് അതിൻ്റെ വരുന്നത്? നമ്മൾ ന്യൂമോണിക് എന്താണ്? That is cows എന്നുള്ളതാണ് അല്ലേ? കലോറിക് ടെസ്റ്റിലെ cows, cold opposite, warm same side. ഓക്കെ, അപ്പം അത് പറയുന്നത് ഡയറക്ഷൻ ആണ്. ഫാസ്റ്റ് കോമ്പനന്റ് എപ്പോഴും ഡയറക്ഷൻ ആണ് കാണിക്കുന്നത്. അപ്പം കോൾഡ് ആണെന്നുണ്ടെങ്കിൽ ഡയറക്ഷൻ ഷുഡ് ബി ടുവേർഡ്സ് ഓപ്പോസിറ്റ് സൈഡ്. അതാണ് കൗസ് എന്ന് പറയുന്നത്. കോൾഡ് വാട്ടർ സ്റ്റിമുലേഷൻ, ദ ഡയറക്ഷൻ ഷുഡ് ബി ടുവേർഡ്സ് ഓപ്പോസിറ്റ് സൈഡ്. സോ ഇതിനകത്ത് കലോറി ടെസ്റ്റ് എവിടെ ചെയ്തു? റൈറ്റ് സൈഡിൽ. അപ്പൊ എങ്ങോട്ടാണ് പോകേണ്ടത്? ഓപ്പോസിറ്റ് സൈഡിലോട്ട്. അപ്പൊ ഫാസ്റ്റ് കോമ്പനന്റ് ഷുഡ് ബി, ഡയറക്ഷൻ ഈസ് ഓൾവേസ് ടോൾഡ് ബൈ ദ ഫാസ്റ്റ് കോമ്പനന്റ്. സോ ഇൻ കോൾഡ് വാട്ടർ the direction should be towards the opposite side. അപ്പോൾ ഇവിടെ റൈറ്റ് സൈഡ് ആകുമ്പോൾ ഡയറക്ഷൻ എങ്ങോട്ടാവണം? ലെഫ്റ്റ് സൈഡിലോട്ടാവണം. അപ്പം ദ ഫാസ്റ്റ് കോമ്പനന്റ് ടുവേർഡ്സ് ദ ലെഫ്റ്റ് സൈഡ്. സോ ഇത് വെച്ചും കൊണ്ട് നിങ്ങൾ ആദ്യം ഒരു ആൻസർ ഉണ്ടാക്കിയതിനു ശേഷം ഈ ആൻസറിലോട്ട് നോക്കിക്കഴിഞ്ഞാൽ കുറച്ചും കൂടി ഈസി ആയിരിക്കും, തെറ്റാൻ ചാൻസ് കുറവാണ്. ഓക്കെ, സോ കലോറി ടെസ്റ്റ് കോൾഡ് വാട്ടർ ആണെന്നുണ്ടെങ്കിൽ ഡയറക്ഷൻ ഈസ് ടുവേർഡ്സ് ദ ഓപ്പോസിറ്റ് സൈഡ്. ഇഫ് ഇറ്റ് ഈസ് എ വാം വാട്ടർ, ഡയറക്ഷൻ ഓഫ് nystagmus is towards the same side. Direction is always shown by fast component. Okay. So direction വേറെ പേരാണ് fast component. So cold water, fast component towards the opposite side. That is the left side. So that is answer. Which of the following is not seen in superior semicircular canal dehiscence? Superior semicircular canal dehiscence. Remember that in superior semicircular canal dehiscence, there is no sensory neural hearing loss. Okay. In superior semicircular canal dehiscence, you will always get a conductive hearing loss. Okay. Autophony will be there in superior semicircular canal dehiscence. Tullio phenomena will be there. Tullio phenomena endana? When the patient is experiencing a vertigo on hearing a loud sound. Loud sound വരുമ്പോൾ എന്ത് വരുന്നു? Tympanic membrane movement വരുന്നു. There will be an air pressure changes in the middle ear. So there is a dehiscence in the superior canal. So the patient will have vertigo. That is Tullio phenomena. Loud sound producing vertigo is Tullio phenomena. And also there will be an oral fullness. So all these will happen in superior semicircular canal dehiscence, but sensory neural hearing loss will not happen in case of a third window syndrome and superior semicircular canal dehiscence, otherwise called third window. There is a third window opening. Okay, what are the two windows? One is an oval window, another one is round window. If there is another one, that is third window syndrome, which is superior semicircular canal dehiscence, in that case, you will get a conductive hearing loss. Okay, so autophony will be there, Tullio phenomena will be there, oral fullness will be there, and also conductive hearing loss will be there. There won't be any sensory neural hearing loss. ഇതൊക്കെ ഭയങ്കര tricky questions ആണ്. Clinical case of vertigo lasting for few seconds associated with movement of head posture. The condition was treated with Epili maneuver. What is the diagnostic test? Epili maneuver diagnostic, position test എന്ന് പറയുന്നില്ലേ? അപ്പം Epili maneuver is usually we are doing in a benign paroxysmal positional vertigo, isn't it? Epili maneuver done in BPPV, and the diagnostic test is Dix-Hallpike maneuver, or the position test is Dix-Hallpike maneuver. Okay. Heimlich maneuver എന്താണ്? Heimlich maneuver നമ്മൾ ഈ ആസ്പിറേഷൻ അല്ലെങ്കിൽ സഡൻ ചോക്കിങ്ങിൽ വെച്ച് ചെയ്യുന്നതാണ് Heimlich maneuver. Brand of exercises are some of the exercises we teach the patient in case of vertigo. Okay. And Dix-Hallpike maneuver is a position test. So that is to diagnose a case of benign paroxysmal positional vertigo. So Dix-Hallpike maneuver is a diagnostic test for BPPV. Epili maneuver is a therapeutic maneuver or corrective maneuver for BPPV. Okay. This already we discussed. Arrange a sequence of auditory pathway from peripheral to central. Peripheral to central ആണ്. അപ്പൊ ഇതാണ് ഇത് വരുന്നത്. ഇതുപോലെ പോണം. അപ്പൊ എങ്ങനെയാന്ന് വന്നത്? Auditory cochlear nucleus ഉണ്ട്. അത് കഴിഞ്ഞിട്ട് പിന്നെ inferior colliculus വരുന്നു. Then auditory cortex ആണ്. അപ്പൊ ഇത് ചിലപ്പോൾ ഇങ്ങനെ മാറി വരാം. ഇതുപോലെ തന്നെ ആവണമെന്നില്ല. പക്ഷെ always remember this echolima that is from periphery to central. അതിനനുസരിച്ചിട്ട് വരുന്നതനുസരിച്ച് കറക്റ്റ് ആയിട്ട് എഴുതിയാൽ മതി. A patient had negative Rini on 256 and 512, but positive response on 1024. That is, the 24 frequency. 256 and 512 negative, 1024 positive. What is the AB gap? This is pale combinations. So you know that there is an AB gap, and this Rini is positive in normal and sensory neural, and Rini become negative in case of conductive hearing loss. So this is the thing. If 256 is negative and 512 and 1024 positive, the hearing loss is around 25 to 30 dB. Okay. So ഇതിനകത്ത് 15 to 30 dB എന്ന് വരാം. അപ്പൊ അതല്ല. ഇവിടെ ചോദിച്ചിരിക്കുന്നത് 256 ഉം 512 നെഗറ്റീവ് ആണ്, and 1024 പോസിറ്റീവ് ആണ്. So the answer will be 30 to 45. And if all are negative, മൂന്നെണ്ണത്തിനും നെഗറ്റീവ് ആയിട്ടുണ്ടെങ്കിൽ 45 to 60 dB ആയിരിക്കും. So the question asked here is, what is the AB gap if 256 and 512 is negative? So there is no confusion. The answer is 30 to 45 dB. അപ്പൊ ഇത് ഓർത്ത് വെക്കണം. ഇതിന്റെ പല കോമ്പിനേഷൻസിന് ക്വസ്റ്റ്യൻസ് ചോദിക്കാം. ഓക്കെ. അപ്പം 256 is negative and the other positive. Okay. So this is important. ഇതിനകത്ത് കൺഫ്യൂഷൻ ഒന്നും, ഇതെല്ലാം ഭയങ്കര സ്ട്രേറ്റ് ക്വസ്റ്റ്യൻസ് ആണ്. ഇത് തെറ്റി കഴിഞ്ഞ് കഴിഞ്ഞാൽ നിങ്ങൾക്ക് ലോസ് ആണ്. ഇതിലൊന്നും ഒരു കൺഫ്യൂഷൻ വരാൻ പാടില്ല. അതൊക്കെ കാണുമ്പോഴേ കറക്റ്റ് ആയിട്ട് ആൻസർ ചെയ്യണം. I think we will skip it. ഇത് പിന്നെ ചോദിക്കുന്നതായിരിക്കും. ടൈമും കുറവാണ്. Development of nose will go very fast. Development of nose actually started 4th week of intrauterine life, and in the cranial ectoderm, you can see a thickening, and again this thickening is called the nasal placard, and after that this thickening will ഒരു thickening ആണ്, അത് കഴിഞ്ഞ് thickening deep ആയിട്ട് മാറും, അത് കുഴിഞ്ഞു പോകും. So there will be a medial nasal process and there will be a lateral nasal. അപ്പോൾ ഒരു pitch ആണ്, അതിനൊരു കുഴി വരുമ്പോൾ അത് രണ്ട് ഭാഗങ്ങളായിട്ട് മാറും. അപ്പോൾ അതൊരു medial nasal processും വരുന്നു, പിന്നെ ഒരു lateral nasal processും വരുന്നു. ഇതാണ് ഓരോ സൈഡിലും വരുന്നത്. And അത് കഴിഞ്ഞിട്ട് ഈ രണ്ട് this medial nasal process from the first arch, there comes an mandibular prominence and a maxillary prominence. Okay, so you can see here as maxillary process and a mandibular process are coming from the other side, and this medial nasal process and the lateral nasal process will fuse with it, and it forms a nose. Okay, so the medial nasal process and this maxillary process will fuse together. അങ്ങനെയാണ് നോസ് വരുന്നത്. അപ്പം ഇത് ഇത്തിരി ടൈം എടുക്കുന്നതാണ്. In single word you can tell it as ഇത്രയും കാര്യങ്ങളെല്ലാം ഓർത്ത് വെക്കണം. Nasal sac is closed posteriorly by the bucco-nasal membrane. Okay, അതായത് ഈ നോസിന്റെ posterior aspect കൊയന വരുന്ന അവിടത്താണ് bucco-nasal membrane. So what will happen if the bucco-nasal membrane is persisting? ഈ bucco-nasal membrane ആണ് ഈ നോസിന്റെ posterior പാർട്ടിലുള്ളത്. അവിടെ നിന്നാണ് നമ്മുടെ nasopharynxലേക്കുള്ള എൻട്രി. And this bucco-nasal membrane should go by birth. If it is persisting, it will lead to a choanal atresia. Okay. And between the two medial nasal process, if there is some deformity, this will act as a nasal dermoid. Okay. And frontonasal process and the maxillary process, usually the frontonasal process and maxillary process join lip formation. This part. If it is not fusing completely, it will lead to cleft lip. Okay. And palatal process of the two sides should meet in midline and along with the septum. If it is not meeting in the midline, it will lead to cleft palate. And there is also a vomeronasal organ of Jacobson that is not present in human. Human adoru vestigial structure aayittu maarana. Appo idinathu orkkanullathu coin latritia happen if there is persistence of the bucco-nasal membrane. Okay. And between the medial nasal process or two side, if there is any problem with fusion, it can lead to a nasal dermoid or the nasal tip bifid ആയിട്ട് ഈ സൈഡിൽ രണ്ടും ബൈഫിഡ് ആയിട്ട് വരും. അപ്പോൾ അല്ലെങ്കിൽ ഒരു nasal dermoid. Nasal dermoid usually happens in the on the root of nose, on the dorsum of nose. Okay, so can be either a nasal dermoid or it can lead to a bifid nasal tip. Tip of nose will be, it's not fusing completely, so it will be bifid ആയിട്ട് വരും. Most common congenital anomaly of the nose is coin latritia because the muconasal membrane is not fusing. And regarding coin latritia, because you know that the children are obligatory nasal breathers. മൂക്ക് അടച്ചു വെച്ച് കഴിഞ്ഞാൽ ഇവർക്ക് ശ്വസിക്കാൻ പറ്റില്ല. അപ്പൊ ഈ കോയിൻ ലട്രീഷ്യ വരുമ്പോൾ bilateral coin latritia is actually an emergency situation where the child will present with respiratory distress and there will be typical cyclical cyanosis. When the child is crying, it will open the mouth so it can breathe through the mouth. So at the time of crying, this cyanosis will be relieved. Okay, കരയാൻ തുടങ്ങുമ്പോൾ വായി കൂടെ ശ്വാസം എടുക്കാൻ പറ്റുന്നതുകൊണ്ട് ആ cyanosis പോകും. And that is very typical of a bilateral coin latritia, and that is called cyclical cyanosis. Okay, and unilateral coin latritia is actually not a emergency. In that case, the child will present with feeding difficulties and also unilateral nasal discharge. And there is also a chance of association with the other congenital anomaly. ഏതാണ് വരുന്നത്? അതാണ് charge association എന്ന് പറയുന്നത്. Charge colobomatosis blindness വരാം. Heart disease. Most common heart disease in a charge association is ASD. Okay, atrial septal defect, atresia of Koina, retarded growth and development, genital hypoplasia in males, and ear deformity with deafness. So that is charge association in association with the coin latritia. So investigation of choices in case of a coin latritia is high resolution CT scan. And emergency management is not surgery. Okay. നമ്മൾ വിചാരിക്കും coin latritia ജനിച്ച ഉടൻ തന്നെ coin latritia surgery ചെയ്യണമെന്ന്. But there is no need of that. There is a need, but the emergency thing you have to do at birth is keep the airway open. ഈ എയർവേ ഓപ്പൺ ആക്കി നമുക്ക് ഓറൽ എയർവേ വെച്ച് കൊടുക്കാം, ഓറൽ എയർവേ വായിൽ വെച്ച് കൊടുക്കാം. എന്നിട്ട് there are so many other investigations you have to do. You have to confirm the presence of coin latritia. Then only we have to go for surgery. And the definitive surgery is transnasal endoscopic repair. Okay, transnasal endoscopic repair is the definite. Transnasally we are putting an endoscope, and then we are identifying the coin latritia site. അവിടെയുള്ളത് ബോണി ഏരിയ ആണോ കാർട്ടിലേജൻസ് ആണോ നോക്കും, എന്നിട്ട് അതിനെ ഡ്രിൽ ചെയ്യും. അതാണ്. അപ്പോൾ സോ transnasal endoscopic repair is a definitive surgery, but there is no need of doing the emergency definitive surgery as an emergency. Okay, so ആദ്യം തന്നെ ജനിച്ച ഉടനെ ഇത് കണ്ടുപിടിച്ചു കുട്ടിക്ക് cyclical cyanosis ഉണ്ട്, then there is a respiratory emergency, then first put an oral airway and wait and do all other investigation, confirm your diagnosis, and then go with the definitive surgery, which is a transnasal endoscopic repair. Okay. So see in this, ഇതാണ് നമ്മളിപ്പം പറഞ്ഞ question. 1 day old child presented with respiratory distress and cyanosis, which improves on crying. Endoscopy of the nose and CT scan was done. Images are attached. See, this is CT scan. High resolution CT scan is the investigation of choice. In this, see, you can see there is bilateral coin latritia. And this is endoscopy. In endoscopy also, this is the posterior end of septum. So here there should be an opening, but In both sides, there is no opening scene. So this is a bilateral coronal atresia. Now choose the most inappropriate statement following this clinical entity. അതൊക്കെ ഭയങ്കര ഇമ്പോർട്ടന്റ് ആയിട്ട് വായിക്കണം. Most appropriate നല്ല ചോദിച്ചിരിക്കുന്നത് inappropriate ആണ്. So this occurs due to persistence of buccal membrane. True. It occurs due to persistence of buccal membrane. That is bilateral and is usually present with respiratory difficulty. True. Failure to pass catheter from nose to pharynx. അങ്ങനെയാണ് നമ്മൾ ഡയഗ്നോസ് ചെയ്യുന്നത്. മൂക്കിൽ കൂടെ catheter ഇടുമ്പോൾ യൂഷ്വലി this should come to the pharynx. നമ്മൾ റൈൽസ് ട്യൂബ് ഒക്കെ ഇടുമ്പോൾ വരുന്നില്ലേ, അതുപോലെ വരണം. പക്ഷേ ഇവിടെ coronal atresia ആയതുകൊണ്ട് അങ്ങനെ ഒരു catheter പാസ് ചെയ്താലും അത് pharynxലേക്ക് വരുന്നില്ല. And so that is also true. And recanalization surgery is done at birth. That is not appropriate. I already told the first thing is to keep an oral airway. And once the investigations are done and you are confirmed, then only go with the recanalization surgery. And the definitive surgery is a transnasal endoscopic repair. So the answer here is recanalization surgery is done at birth. It is not appropriate. It's not appropriate. Okay. This paranasal sinus, yeah, we have half an hour also. In paranasal sinus, just remember these things. Frontal sinus is absent at birth, and frontal sinus is the last to complete development. Okay, frontal sinus is absent at birth. Then maxillary sinus is otherwise called antrum of Highmore, and this is the first sinus to appear radiologically. And final size in the 17th to 18th year of life. Okay. And so frontal sinus and sphenoid sinus is not, actually it's not completing its development at birth. Ethmoid sinus and maxillary sinus will be there. So frontal sinus is absent at birth and the sphenoid sinus is first to reach full development. Okay. And maxillary sinus reaches the final size or adult size by puberty, by 17 to 18 years of life. And in the regarding the frontal sinus ഇതാണ് frontal sinus. അപ്പോൾ അതിന്റെ lateral viewനകത്ത് നിങ്ങൾക്ക് കാണാം frontal sinusന് ഒരു anterior wall ഉണ്ട്, frontal sinusന് ഒരു posterior wall ഉണ്ട്. Anterior wall diploic ആണ്, so there is chance of osteomyelitis. Posterior wall is cancellous wall. Okay, so there is an anterior wall and a posterior wall. And this frontal sinus is absent at birth. Okay, ഇത് ഇപ്പോൾ എന്താണ്, ഇതാണ് നമ്മുടെ scalloping appearance കാണിക്കാൻ വേണ്ടിയിട്ടാണ്. This normal appearance is a scallop. Scallop ഒരു ഷെല്ലാണ്. Scalloping appearance ആണ് നോർമലി ആയിട്ട് വരുന്നത്. അതിന്റെ സിഗ്നിഫിക്കൻസ് എന്താണ്? Scalloping. So loss of scalloping with the expansion of the sinus is typical of a mucocele. Frontal sinus mucocele-നകത്ത് this scalloping appearance will be lost. In X-ray itself, you can diagnose. So loss of scalloping with expansion of the sinus in an X-ray paranasal sinus is typical of frontal sinus mucocele. Okay, frontal sinus mucocele, loss of scalloping. And if there is an hyperpneumatization, can happen either in normally and also in acromegaly. Okay, hyperpneumatization happen in normals and also in acromegaly. So loss of scalloping in frontal mucocele and hyperpneumatization can happen in normal or also in an acromegaly. This is normal. The compare normal appearance. This is hyperpneumatization. Ethmoid sinus ethmoid sinus is actually there is 3 to 13, from 3 to 13 to 20 to 200. Ethmoid sinus number can vary widely from 3 to 200 cells. There is an anterior group and also there is a posterior group. എങ്ങനെയാണ് division വരുന്നത്? Anterior groupനെയും posterior groupനെയും തമ്മിൽ ഇടയിലായിട്ട് എന്താ ഉള്ളത്? There is a basal lamella or a ground lamella. So actually there is one ethmoid bone. Okay, only one ethmoid bone which is like a cross. ഒരു cross ആണ്. ഇതിനകത്ത് there is a vertical part and there is a horizontal part. ഈ vertical പാർട്ടിനകത്താണ് ബ്രെയിനകത്തോട്ട് skull baseനകത്തോട്ട് base of skull crista galli and the lower part is perpendicular plate of ethmoid. So this is like a cross, only one ethmoid bone. It is like a cross and the vertical part crista galli and perpendicular plate of ethmoid. And in the cross part, There is cribriform plate and also the lateral part. Okay. And sinuses are in between. So, in ground lamella, anterior is anterior groove and posterior is the posterior groove. Okay. And the anterior groove drain into middle meatus and the posterior groove drain through the sphenoethmoid recess into the superior meatus. Okay. So, anterior ethmoid cells drain into middle meatus and the posterior groove drain into superior meatus. And also in ethmoid cells, you have to remember, as ഇതാണ് ഞാൻ പറഞ്ഞ ഒരു vertical പാർട്ടും ഉണ്ട് ഒരു horizontal പാർട്ടും ഉണ്ട്. ഇതിൽ vertical പാർട്ടിനകത്താണ് crista galli and perpendicular plate of ethmoid, which is uniting with the nasal septum. And in the horizontal part, there is cribriform plate and also fovea ethmoidalis. Okay. And this forms the medial wall of orbit, lamina papyracea. It's a thin lamina എന്ന് വെച്ച് കഴിഞ്ഞാൽ thin bony plate. A paper-like bony separation between the orbit and the ethmoid cells. And other part, it forms the medial wall of orbit. Also, frontal process of maxilla, lacrimal bone, and body of sphenoid also forms the medial wall of orbit. So, medial wall of orbit is formed by lamina papyracea along with frontal process of maxilla, lacrimal bone, and the body of sphenoid. Okay. And there are also two other cells. One is a Haller cell and another one is an Onodi cell. So, Haller cell is an ethmoid cell which is seen on the floor of orbit. Okay, infraorbital ആയിട്ട് കാണുന്ന ഒന്നാണ് Haller cell. And Onodi is in relation to the optic nerve. So, O for O. Onodi cell in relation to the optic nerve, and injury to the Onodi cells can lead to optic nerve injury and also retrobulbar neuritis. Okay. And optic nerve injury and retrobulbar neuritis can happen if you damage the Onodi cell by accidentally during a functional endoscopy sinus surgery, right? So, Haller cell and Onodi cell, Haller cell in relation to the floor of orbit or to the infundibulum, and Onodi cell in relation to the optic nerve. Infundibulum മനസ്സിലായല്ലോ. Infundibulum means on the, it will, this is maxillary sinus. And this is the drainage site of maxillary sinus into the middle meatus. So, if these Haller cells are infected or if the Haller cells are highly pneumatized, there is chance of obstruction to the drainage of maxillary sinus. Okay, so this can lead to maxillary sinusitis. And Agarnaceae and frontal recess cells are again they are and ethmoid cells which are in relation to the frontal sinus. So, Agarnaceae and frontal recess cells related to frontal sinusitis. Onodi cell, again, it's a ethmoid sinus cells which are related to the optic nerve. And Haller cells are related to the infundibulum and also infraorbital area. So, cells again, ethmoid sinus, there are 5 named cells, 2 constant and 3 variable. Constant one is ethmoid bulla. Ethmoid bulla you may be knowing as largest anterior ethmoid cell. Agarnaceae we already told us anteriormost ethmoid cell. These two are constant. This can happen in everyone. You have the ethmoid bulla. I have the ethmoid bulla. You have Agarnaceae. Everyone has Agarnaceae. They are constant. They are ethmoid sinus cells. But Onodi cell, Haller cell, and conga bullosa is variable. It is not mandatory that every human should have these cells. Onodi, I already told you. Onodi, optic nerve. Haller, orbital floor. Conga bullosa is a pneumatized middle turbinate, which is very common. Okay, so this conga bullosa is one of the most common variation of the ethmoid sinus cell, right? So, Onodi, Haller, and conga bullosa are variable. They are not constant, but ethmoid bulla or bulla ethmoidalis and Agarnaceae cell. Agarnaceae cell is related to frontal sinus, floor of frontal sinus. Frontal recess cells are again related to the frontal sinus. Here you can see, this is the ethmoid bulla. It is the largest anterior ethmoidal cell. And Agarnaceae is something related to this frontal sinus. So, if the Agar cell is very large and it is causing blockage of frontal sinus, it's lead to frontal sinusitis. Okay. So, ethmoid bulla and Agarnaceae are constant cells seen in everyone. This you know, I know that frontal anterior ethmoid and maxillary sinus open into middle meatus. You know that uncinate process, bulla ethmoidalis and ethmoid infundibulum. And also the osteometal unit is something in the middle meatus. Osteometal unit is it's an area in the middle meatus where the frontal, anterior ethmoid and the maxillary sinus open. Frontal, anterior ethmoid and maxillary sinus open into the middle meatus through the osteometal unit. And this osteometal unit is a key area of a functional endoscopy sinus surgery. Okay. So functional endoscopy sinus surgery the main area or the key area is an osteometal unit, otherwise called an osteometal complex. OMU number, OMC number. Because avideana ee anterior group of cells in the drainage varuna. That is the frontal, then the anterior ethmoid and maxillary. So that is a key area of a functional endoscopy sinus surgery. Superior meatus lobe open cheyyunnathu posterior ethmoid and sphenoid aanu through the sphenoethmoid recess. Okay. Ethmoid sinuses are well developed at birth, and hence infants and children below 3 years of age are more likely to have an acute ethmoiditis. Right? So, well developed at birth? Well developed, the most important one is ethmoid sinus. Above the age of 3, adult maxillary sinusitis are more commonly seen, but because the maxillary sinus become fully grown by age of puberty. So in children, the ethmoid sinuses are well developed, so there is more chance of an acute ethmoiditis, and in adult, maxillary sinus is more common. This is also important. Foramina of Breschet, there are various drainage channels located in the posterior wall of frontal sinus. So there is a condition called Pott's puffy tumor. Pott's puffy tumor. That is, frontal sinus forehead a compressible lesion compressible swelling in the forehead, which can happen as a complication of frontal sinusitis. And this is through the foramina of Breschet, where there is venous channels located, and from the brain, this venous channels will come, and after infection of the frontal sinus. So, this is a compressible swelling aayitana Pott's puffy tumor varune. It is happening as a complication of frontal sinusitis, and the main culprit or pathology lying behind that infection of the venous channels through foramina of Breschet. Okay. And the most common sinus involved in adult in order of frequency. Already we told first is maxillary, then frontal, then ethmoid, and then sphenoid. ഇങ്ങനെയാണ് സൈനസൈറ്റിസിന്റെ ഫ്രീക്വൻസി വരുന്നത്. ഏറ്റവും കൂടുതൽ വരുന്നത് മാക്സിലറിയിലാണ്, അത് കഴിഞ്ഞിട്ട് പിന്നെ ഫ്രോണ്ടല്, പിന്നെ എത്മോയിഡ്, സ്പിനോയിഡ്. അതേസമയം കുട്ടികളിലാണെങ്കിൽ ഏറ്റവും കോമൺ ആയിട്ട് വരുന്നത് എത്മോയിഡ് സൈനസൈറ്റിസ് ആണ്. ഓക്കെ. ആൻഡ് അഡൾട്ട് ഇറ്റ് ഇസ് മാക്സിലറി. തേർഡ് ആണ്, അഡൾട്ടിൽ തേർഡ് ആണ് എത്മോയിഡ്, പക്ഷെ കുട്ടികളിൽ ഫസ്റ്റ് ആണ് എത്മോയിഡ് സൈനസിന്റെ ഇൻവോൾവ്മെന്റ്. Then the nose develop from, nose develop from first branchial arch. Okay, nose is developing from the first branchial arch. Right. Paranasal sinus present at birth. Which are the paranasal sinuses present at birth? Frontal is absent at birth. So frontal combination then sphenoid is also it's not fully formed at birth. So the paranasal sinus present at birth are ethmoid and maxillary. Okay, there is no confusion. Answer. Then match the following. Frontal sinus in the best view in X-ray. Frontal sinus best view is Cardwell view. Okay, frontal sinus best view is Cardwell view. Maxillary sinus, there is no confusion. It is Waters view or occipito-Mendel view. Then superior orbital fissure, the best view is again Cardwell view. Frontal sinus and superior orbital fissure, the Cardwell view in X-ray. Inferior orbital fissure, it is Towne view, and optic foramen, it is the Rees view. Okay, so frontal sinus and superior orbital fissure is best seen in a Cardwell view. Maxillary sinus in occipito-Mendel view or Waters view, and optic foramen we see in a Rees view. And the submendovertical view, submendovertical view is the best view for sphenoid sinus. Okay, submendovertical view or the skull base view. Remember, as the sphenoid sinus is sitting in the skull base. So the best view for sphenoid sinus is skull base view. which is otherwise called submendovertical view. Okay. Then, in set in image what is this? Common swelling in the root of nose. That's tip infection like meningitis, brain abscess can happen. And differential diagnosis of this is meningoencephalocele or a glioma. What is it? Any idea? We already discussed regarding about this. It is nasal dermoid. Okay, nasal dermoid. Nasal dermoid. It is a congenital malformation. And the main differential diagnosis is meningoencephalocele. And the differentiating in the feature and the meningoencephalocele is compressible. Meningoencephalocele is compressible. Dermoid system, glioma is not compressible. Okay, and AV malformations are not common towards the root of nose, right? So what is the investigation of choice of a nasal dermoid? It is MRI scan. Okay. Annale, you differential diagnosis the meningoencephalocele glioma, and this meningoencephalocele glioma is basically soft tissue swellings. So MRI scan is the investigation of choice. Meningoencephalocele. If it is a meningoencephalocele, it will be pulsatile or compressible swelling on the root of nose. That is called the Furstenberg sign. Sometimes they will ask us Furstenberg sign is positive. If Furstenberg sign is positive, your only diagnosis is meningoencephalocele. Nasal dermoid and gliomas are not compressible swelling. And investigation of choice is MRI scan. And if you want to detect a bony abnormality, then only go with the CT scan. Otherwise, if it is a soft tissue swelling, the investigation of choice will be always MRI. Okay, MRI scan for soft tissue. So in meningoencephalocele, the investigation of choice is MRI. Also with the nasal dermoid. A polypoidal swelling is noted in infant near the glabella. The swelling is compressible and increase in size on cuffing. That is Furstenberger sign is positive. All of the following investigations should be done except. So from the scenario, we know that it is a meningoencephalocele. So can you do a biopsy in a meningoencephalocele? Never do a biopsy. You can do a CT scan. You can do an MRI scan. You can do an anterior rhinoscopy. So biopsy should not be done in case of meningoencephalocele. Okay. Then say Furstenberger sign is positive in case of meningoencephalocele, nasal encephalocele. Then a 2-year-old infant brought to OPD by mother with case of frequent nasal blockage. On examination, solitary polypoidal mass is seen arising from the roof of nose. The first step in the investigation. No. Okay, this is on the roof of nose, arising from the roof of nose, solitary polypoidal mass. So it is inside, it is not outside, it causes nasal blockage. So for inside the nose lesions, we always do a CT scan because then only we can get the osteometal complex and all the other bony areas. If it is a meningoencephalocele or an external nasal glioma or something, then we have to go with an MRI. But inside the nose, all the polypoidal masses or the differential diagnosis of nasal blockage, all these in cases go with the CT scan. CT scan is a first investigation. 2-year-old child is brought to the hospital with a compressible swelling at the root of nose. 2-year-old child with a compressible swelling. So most likely diagnosis, again, meningoencephalocele. Okay. What is this one? This is MCQ. This is, it's not, don't write it as ranulite. Ranula occurs on the floor of mouth. Floor mouth in the floor ranula. This is nasolabial cyst. And what is a nasolabial cyst? It is arising from the epithelial remnants of the lateral and medial nasal process, maxillary process, and nasolacrimal duct. This is not from odontogenic epithelium. Okay, nasolabial cyst As the name suggests, it is something related with the nose, something related with the nasolacrimal duct. Don't think as it is arising from the odontogenic epithelium. It is nothing to do with the odontogenic epithelium. That is very important. This is a very tricky question. Nasolabial cyst is not arising from odontogenic epithelium. It is common in female in the age group of 13 to 40 years, and usually it is unilateral. Treatment is excision via sublabial route. See, so we put an incision in the sublabial area, and this is removed in toto. Okay, so excision through a sublabial incision, nasolabial cyst. It's not arising from the odontogenic epithelium. I think we are running out of 10 minutes more. Okay. Cleft lip, just remember the repair. We do at 3 months, and also remember the rule of 10. Okay. Age more than 10 weeks, weight more than 10 pounds, hemoglobin more than 10 gram, and total count should be less than 10,000. So that is rule of 10 for cleft lip. And unilateral, we usually do the Millard's repair, and bilateral, it is Butte 3/3 repair. പേര് ഓർത്ത് വെച്ചാൽ മതി. പിന്നെ വായിക്കേണ്ടി വരും. ലാസ്റ്റ് മിനിറ്റ് ഫ്രഷൻ റിപ്പയർ, ലാസ്റ്റ് മിനിറ്റ് റിവിഷന് ഇതും കൂടി ഇൻക്ലൂഡ് ചെയ്യണം, അല്ലെങ്കിൽ പെട്ടെന്ന് മറന്നു. And for cleft palate, the speech abnormality is rhinolalia aperta, open voice, because it's all are open. So it's an open voice. And repair is usually done at 9 to 12 months. And this is the VY repair is done for a cleft palate. Kalnan criteria is for submucous cleft palate. And the submucous cleft palate is a contraindication for adenoidectomy. So what is Kalnan criteria? One is a bifidula. Here you can see a bifidula. Then white line or the zona pellucida. And also, if you palpate on the hard palate, there will be a posterior notch on the posterior end of hard palate. So bifidula, the zona pellucida, and a bony notch in the posterior end of hard palate. There are 3 of them is a Kalnan criteria. It's a diagnostic of submucous cleft palate, and the submucous cleft palate is a contraindication for adenoidectomy. Okay. Then shape of septal cartilage, you know, it is quadrilateral. The part between 2 nasal vestibule, it's very simple. 2 nasal vestibule, you know, this is 2 nasal vestibules, and the part in between is a columella. This part here, this is columella. And the osteocartilaginous junction on the dorsum of nose, we call it as rhinion, which is here. Osteocartilage, this part, rhinion. Okay, this part, this between the septum, between the nasal bone and the upper lateral cartilage. Okay, this is upper lateral cartilage, this is a lower lateral cartilage. So between the bone and the cartilage, this area is a rhinion. Okay, this is a rhinion. So that is rhinion. And external nose is formed from 3 paired and 1 unpaired cartilage. ഇതിനകത്ത് അത് കാണും. 3 paired cartilages are there. 1, 2, and this one, and the septum. Okay, and unpaired cartilage is the septum. So external nose is formed from 3 paired and 1 unpaired. Paired ഏതൊക്കെയാണ്? upper lateral cartilage ഉണ്ട്, lower lateral cartilage ഉണ്ട്, പിന്നെ ആ lower lateral cartilageന്റെ മുകളിൽ ഇരിക്കുന്ന sesamoid lesser alar എന്ന് പറയും, sesamoid cartilages. These 3 are paired, and septal cartilage is unpaired. Okay, so external nose എന്ന് പറയുമ്പോൾ അതിനകത്ത് വരുന്ന കൺഫ്യൂഷൻ, നിങ്ങൾ വിചാരിക്കും സെപ്റ്റം എക്സ്റ്റേണൽ അല്ലല്ലോ എന്ന്. പക്ഷെ സെപ്റ്റത്തിന്റെ ഒരു പാർട്ട് ഈ എക്സ്റ്റേണൽ നോസിലോട്ട് ഒരു കണക്ഷൻ ഉണ്ട്. സോ ദാറ്റ് ഈസ് ഓൾസോ ഇൻക്ലൂഡഡ് അലോങ് വിത്ത് എക്സ്റ്റേണൽ നോസ്. ബിറ്റ്വീൻ ദ 2 lateral cartilages, septum is coming in the midline. So external nose is formed from 3 paired cartilages and 1 unpaired cartilage, which is a septal cartilage. Okay, 3 paired and 1 unpaired. Coena, you know, it is posterior nares. This is anterior nares, and behind is a posterior nares, which is called coena. And the direction of the nasolacrimal duct, this from the lacrimal gland then upper punctum, lower punctum, upper canaliculus and the lower canaliculus coming joining as a common canaliculus. Then the lacrimal sac coming down as a nasolacrimal duct. So here see, what is the direction? It is downwards, forwards and medially. Medially in the sense this is lateral and this is medial. So this is going downwards, forwards and medially. Okay, it is going, direction of nasolacrimal duct is downwards, forwards and medially. And it is opening into which meatus? Nasolacrimal duct is opening into the inferior meatus through valve of Hayes-Nack. Okay. Inferior meatus open chain. This one, hypertrophy of sebaceous gland of the nasal trip is called rhinophyma. This is usually asked in INISET image folder. Treatment is carbon dioxide laser excision. Then there are some areas of the nose. You should be, I am not going into detail. Soft triangle, you should know what is soft triangle, what is K area, dangerous area of face, dangerous area of nose, and also the olfactory area. Soft triangle is something coming here. This can happen as a complication of rhinoplasty. This usually, if that area is injured, there is chance of post-operative notching. Okay, soft triangle injury leading to post-operative notching or scarring, which is a complication of rhinoplasty. And K area is a keystone area. That we have rhinion nasal bone in upper lateral cartilage and and the upper and lower lateral cartilage and scroll area. Okay, that is scroll area. And dangerous area of face, you know, this is this triangular area. And the dangerous area of nose is olfactory area. Okay, dangerous area of nose in the nose face face in the nose in olfactory area. Okay, this you may be aware of these areas, but don't confuse between dangerous area of face and dangerous area of nose. Roof of olfactory region, you know, it is roof of olfactory region. Inside the nose, the roof is by the cribriform plate of ethmoid. Okay. And another one is nasal valve area. You time remind you. Up to what time you can sit? Okay, I'll take 5 more minutes. Okay. (9:30). Oh, fine. Okay. Then I'll stop at 9:30. Fine. Excellent. Nasal valve is bounded by all except. Endana nasal valve? Nasal valve in oribadu questions choikkuneyana. So what is nasal valve? See, there's an area inside the nose. This is nasal valve. So this is the area inside the nose where there is maximum resistance to the flow of air. So that is formed by the nasal septum, the upper lateral cartilage, and the anterior end of head of inferior turbinate. Okay. So anyway, there is nasal septum is there. Then the upper lateral cartilage is there. And either it's a pyriform aperture or the head of inferior turbinate. So it is a superior turbinate. Anyway, the superior turbinate will not come here. Okay. So this is nasal valve area. So the answer will be superior turbinate. So remember this area. So laterally there is a cartilage, upper lateral cartilage. Then medially there is nasal septum, and anteriorly there will be head of inferior turbinate, and laterally pyriform aperture also comes there. So everything comes except the superior turbinate. So that is the nasal valve area. Internal nasal valve is bounded by. Internal nasal valve boundary is the upper lateral cartilage. Okay. So this is the confusion. Internal nasal valve is that. So this is upper lateral cartilage. So this is upper lateral cartilage. So in the boundary is the upper lateral cartilage. Patency of nasal valve is checked by the test. nasal passage will be assessed. Then after that, we do the Cotles test, and again we ask for the ease of breathing. So if it is better, that means nasal valve area is blocked, because on pulling the cheek upwards and laterally, if there is opening, that means Cotles test is positive. Calorie test, you know. Rhinoscopy is examination of nose. Probing we do for any mass lesions. Nasal polyp ഒക്കെ ആണെങ്കിലാണ് നമ്മൾ probe ചെയ്ത് നോക്കും. അത് mobile ആണോ, അതിനകത്ത് bleeding ഉണ്ടോ, whether it is sensitive or not. For all that we do probing. So the answer is Cotles test. This is Cotles test. Okay. So Cotles test indicates abnormality of the vestibular component of the nasal valve. We can also test the patency of the nasal cavity by doing a spatula test. Spatula test ഇവിടെ വെച്ചിട്ട് ask the patient to breathe through the nose and you look for the fogging. And cotton wool test, we keep it's very subjective test. We keep a cotton wool here and ask the patient to breathe, and if it is moving, we compare the movement. So the most confirmatory or most a bit of objective one is a Cotles test. എങ്ങനെയാണ് നമ്മൾ കുറച്ചും കൂടി അതിനെ ഒബ്ജക്റ്റീവ് ആക്കുന്നത്? മാനോമെട്രി ചെയ്യുന്നു. പ്രഷർ അസസ് ചെയ്യാൻ വേണ്ടിയിട്ട് ഒബ്ജക്റ്റീവ് ആയിട്ട് പ്രഷർ അസസ് ചെയ്യാൻ ആദ്യം ചെയ്യും. അത് കഴിഞ്ഞിട്ട് Cotles ടെസ്റ്റ് ചെയ്തിട്ട് ഒരിക്കൽ കൂടി നമ്മളത് പിന്നെ റെസിസ്റ്റൻസ് മെഷർ ചെയ്യും. അപ്പൊ ഇംപ്രൂവ് ചെയ്യുന്നുണ്ടെങ്കിൽ Cotles ടെസ്റ്റ് ഇസ് പോസിറ്റീവ്. Then functions of nose, we think that it's very easy. It's a respiration, olfaction, humidification, resonance to voice, protection of lower airway, and reflex function. And nasal resistance is measured by rhinomanometry. And the question of which of the following is not a function of nose? So olfaction is correct. Humidification, yes. Temperature control of inspired air, yes. Air pressure control, it's not a function. Air pressure control is not a function of nose. Respiration and olfaction and humidification and voice in resonance കൊടുക്കുന്നുണ്ട്, lower airway protection കൊടുക്കുന്നുണ്ട്, reflex function in the sense നമ്മൾ ചിലപ്പോൾ എന്തെങ്കിലുമൊക്കെ ഒരു ഇറിറ്റൻസ് ഒക്കെ ചെല്ലുമ്പോൾ നമ്മൾ കുറച്ച് സ്നിഫ് ചെയ്യും, മൂക്ക് ചീറ്റും അല്ലെങ്കിൽ നമ്മൾ തുമ്മുമൊക്കെ ചെയ്യുന്നുണ്ട്. അതാണ് റിഫ്ലക്സ് ഫംഗ്ഷൻ എന്ന് പറയുന്നത്. എയർ പ്രഷർ കൺട്രോൾ ഈസ് നോട്ട് എ ഫംഗ്ഷൻ ഓഫ് നോസ്. ഓക്കെ. Then air current during the phase of respiration. Usually during inspiration, there is not much of resistance. So it is a lamellar flow. But during expiration സമയത്താണ് eddy current, അതായത് turbulence കൂടിയിട്ട് eddy currents will form. Okay, so this currents will be different in case of expiration. Okay, eddy current and the resistance will be more of a turbulent flow. Inspiration സമയത്ത് അത് lamellar flow ആയിട്ടാണ് പോകുന്നത്. അതുകൊണ്ടാണ് during inspiration the air is not reaching the olfactory area. അപ്പം പെട്ടെന്ന് ഒരു ചെറിയ സ്മെല്ലൊക്കെ ആണെങ്കിൽ ഇൻസ്പിറേഷൻ സമയത്ത് കിട്ടണമെന്നുണ്ടെങ്കിൽ നമുക്കൊന്ന് ആക്റ്റീവായിട്ട് അതിനെ വലിച്ചു കയറ്റേണ്ടി വരും. നമ്മളിങ്ങനെ നോക്കില്ല നല്ല മണമാണോ എന്ന് അറിയാൻ വേണ്ടി നമ്മൾ സ്നിഫ് ചെയ്ത് നോക്കും. സോ ആക്റ്റീവ് സ്നിഫിങ് വേണം. ദാറ്റ് ഈസ് ബിക്കോസ് ഡ്യൂറിങ് ഇൻസ്പിറേഷൻ ഇറ്റ് ഇസ് ലാമെല്ലാർ ഫ്ലോ ആൻഡ് ഇറ്റ് ഈസ് നോട്ട് റീച്ചിങ് ദ ഓൾഫാക്ടറി ഏരിയ. ഓൾഫാക്ടറി ഏരിയ എന്ന് പറയുമ്പോൾ ഈ ഒരു ക്രിബ്രിഫോം പ്ലേറ്റിന്റെ റൂഫിലേക്ക് പോകണം. അപ്പൊ ഇൻസ്പിറേഷൻ സമയത്ത് അത് റൂഫിലേക്ക് പോകുന്നില്ല. അതേസമയം expiration സമയത്ത് there is a turbulent flow. It is going into the roof and also it is ventilating the paranasal sinuses. Okay, അപ്പൊ expiration സമയത്താണ് അത് olfactory ഏരിയയിലേക്കും പോകുന്നുണ്ട്, പിന്നെ paranasal sinusuകളെ വെന്റിലേറ്റ് ചെയ്യുന്നുണ്ട്. So lamellar flow in inspiration and turbulent flow in expiration. See question. During inspiration the main current of airflow in a normal nasal cavity is through. എങ്ങനെയാണ് പോകുന്നത്? Middle part of cavity in the middle meatus in a parabolic. Middle part കൂടെ തന്നെയാണ് പോകുന്നത്. Because you see here, it is going through the middle part of the middle meatus. It is going through the middle part of middle meatus in a parabolic curve. It is not going through the lower part. It is not going through the superior part because we already told it is not reaching the olfactory area in an inspiration. Inspiration ആണ് പറഞ്ഞിരിക്കുന്നത്. So it is not reaching the superior meatus. It is not going through the olfactory area. It is not going through the lower part. During inspiration, the main current is in the lamellar flow and it is going through the middle part of the nasal cavity in the middle meatus in a parabolic curve. Okay. All these structures are found in the lateral nasal wall except superior turbinate, yes. Vomer is a bone which is seen in the septum. Okay. Agarnase, again we told it is in the lateral wall, which is a part of ethmoid bone, ethmoid air cells. And Haynes wall, it is again the valve of the nasolacrimal duct, which is opening into the lateral wall, where it is into the inferior meatus. So all these are in the lateral wall, except vomer, which is the part of a nasal septum. Okay. Lateral wall, we know it is superior turbinate is there, middle turbinate, inferior turbinate, and also the meatate. And conga bullosa is the most common abnormality that we already discussed. It is an hypertrophied and pneumatized middle turbinate. You know there is 3 turbinated meatate. Inferior turbinate is the largest and it is separate bone. Middle and superior turbinate are part of ethmoid bone. And in the inferior meatus, it opening into the nasolacrimal duct through Haynes valve, and this it is going downwards, backward, forward. Sorry, it is forwards and lateral. Passavant's ridge. What is Passavant's ridge? It is formed by Passavant's ridge. It's formed by palatopharyngeus. Okay, Passavant's ridge, PNP. So remember that it's not palatoglossus, it is pharyngeus. Passavant's ridge is something going to the related to the posterior pharyngeal wall. So palatopharyngeus, Passavant's ridge. Some injuries or absence of closure will lead to velopharyngeal insufficiency. Okay, so it is palatopharyngeus forming the Passavant's ridge. Onodi cell and Haller cell are seen in relation to. Onodi is the optic nerve. Haller cell, we told it is in the floor of orbit, isn't it? So onodi, optic nerve, and Haller is seen in the floor of orbit in relation to the infundibulum, isn't it? So the if it is enlarged, it can lead to block of the infundibulum, which can lead to the normal flow of maxillary sinus into the middle meatus, leading to maxillary sinusitis. So onodi, optic, Haller, floor of orbit. Okay. So O and O. ഇതിനകത്ത് വേണമെങ്കിൽ ഹാലർ ആൻഡ് ഫ്ലോറിന്റെ എൽ വെച്ച് നോക്കാം, അങ്ങനെയെങ്കിൽ ഓർക്കണം. Okay. Onodi with optic nerve, Haller with floor of orbit. And Agarnase again can lead to, if it is enlarged, it can compress on the lacrimal sac area, leading to epiphora. Frontal recess cells can block the frontonasal duct also. All these are related to the frontal sinus and also with the lacrimal sac. X-ray view we already discussed, isn't it? That match the following at the Varnana. Waters view is best view for maxillary sinus, otherwise called a 30-degree occipito-mental view. That is the commonest view for a paranasal sinus. Okay. X-ray paranasal sinus Waters view. Waters view is 30-degree occipito-mental. That is the occiput in the X-ray beam. Film, X-ray film. So occipito-mental view. Okay. That is Waters view. Then for frontal sinus, we would keep to see the frontal sinus clearly, the view is Cadwell view or occipito-frontal view. Then sphenoid sinus is in the skull base, so we have to take the submental vertical view. Ethmoid sinus in lateral oblique view. And in the lateral view, you can also see posterior wall of frontal sinus and also the sphenoid sinus. So, but the best view for sphenoid sinus is skull base view or submental vertical view. Then the lateral view of nasopharynx to grade the adenoid hypertrophy. And the lateral view of skull is for best view for sella turcica. Calcification in X-ray PNS, you can see either in an inverted papilloma or a meningioma or a chordoma. And suprasellar calcification is very common in craniopharyngioma. Radiological imaging of noise for choice in nose and PNS is CT scan. Okay, if it is, we already discussed that. If the structure is externally compressible swelling, we go with an MRI scan. But the inside the nose swelling, always radiological imaging of choice is CT scan. For paranasal sinus, the imaging of choice is CT scan. Okay. In Waters view, which sinus cannot be visualized? Waters view open mouth allengil. In a normal Waters view is not open mouth. Modified Waters view on open mouth. So So open mouth ഇല്ലാന്നുണ്ടെങ്കിൽ നിങ്ങൾക്ക് sphenoid sinus കാണാൻ പറ്റില്ല. So in a water's view, sphenoid sinus cannot be visualized. All the other three, maxillary, frontal, and ethmoid can be visualized, but sphenoid sinus cannot be visualized. If it is modified water's view or submendo occipitomental view with open mouth, then you can see the sphenoid sinus. Okay, so the answer is sphenoid. In basal view, the sinus which can be best seen, skull base view, basal view എന്ന് പറയുന്നത്. It is the sphenoid sinus. Okay, or submendo vertical view, it is sphenoid sinus. Yeah, correct, good. Best view for frontal sinus, it is Cardwell view. Describe it. Then wall of maxillary sinus are sinus. The walls of maxillary sinus are related to walls of maxillary sinus. Floor of orbit maxillary sinus ഉണ്ട്. പക്ഷേ floor of orbit upper posterior teeth ഉണ്ട്. Floor of orbit upper posterior teeth and infratemporal fossa. Floor of orbit upper posterior teeth, infratemporal fossa and hard palate. Hard palate is not related to maxillary sinus. Okay, hard palate is not related to maxillary sinus. The wall of maxillary sinus are related only to the floor of orbit, upper posterior teeth, and the infratemporal fossa. Okay, hard palate, don't confuse it. Hard palate is not in relation to the maxillary sinus. Okay, maxillary, we are thinking about the maxillary sinus. So maxillary sinus is not related to hard palate. The maxillary sinus is innervated by, it is not stratified squamous epithelium, it is a respiratory epithelium. Maxillary sinus is not draining into superior meatus, but it is draining to the middle meatus. It is innervated by branches of the maxillary division of the trigeminal nerve. Okay, right. So answer is innervated by branches of maxillary division of trigeminal nerve. It's common with rest of respiratory tract. Air sinuses are lined by respiratory mucosa. All the paranasal sinuses are lined by respiratory mucosa. And the maxillary sinus draining to the middle meatus, and blood supply is from the third part of maxillary artery. The first part no, maxillary sinus is receives blood supply from third part of maxillary artery through superior alveolar artery. The superior alveolar nerve innervate the sinus and maxillary teeth. Adundana toothache sinusitis varumba namukku toothache kudu. So it is a third part, and all the sinuses are lined by respiratory mucosa. And one word about the allergy fungal rhinosinusitis, very important topic, repeatedly asked. This is a CT scan finding. Okay, ഇതിനകത്ത് ഈ CT സ്കാനിനകത്ത് എന്താണ് ഡിഫറെന്റ് ആയിട്ട് കാണുന്നത്? ഇതിനകത്തൊരു ഹോമോജിനസ് ഒപ്പാസിറ്റി ആണ്. ഹോമോജിനസ് ഒപ്പാസിറ്റി എന്ന് വെച്ച് കഴിഞ്ഞാൽ ഒരുപോലെയുള്ള ഒപ്പാസിറ്റി. Okay, so in this is a coronal CT scan, coronal view, CT scan, paranasal sinuses, coronal view. Coronal view is this type of coronal view. You can see the these are the orbit. This is a nasal cavity and the maxillary sinus. Here you can see an homogeneous opacity, and this homogeneous opacities are maybe an androcoinal polyp. That is andrum of Highmore maxillary sinus in the vera pere. Andrum of Highmore. So androcoinal, that is polyp arising from the andrum, that is from the maxillary sinus, and it is going to the coina posteriorly. So polyp, all polyp, androcoinal polyp avate, ethmoid polyp avate, നമ്മൾ CT സ്കാൻ എടുക്കുമ്പോൾ ഹോമോജിനസ് ഒപ്പാസിറ്റി ആയിരിക്കും. എല്ലാ സ്ഥലങ്ങളും ഒരുപോലെ ആയിരിക്കും, ഒരുപോലത്തെ ഒപ്പാസിറ്റി ആയിരിക്കും. അതേസമയം see here, this is double density. Here it is not an homogeneous opacity. അതായത് ഹോമോജിനസ് ആയിരിക്കുന്നതിന്റെ ഇടയിൽ വെളുത്തിരിക്കുന്നതിന്റെ ഇടയിൽ കുറച്ച് കൂടുതൽ കളേഴ്സ് കാണാം അല്ലേ? So it is called a heterogeneous opacity. It is heterogeneous opacity. That is because ഈ homogeneous opacity വരുന്നത് ഈ ഒരു ഇൻഫ്ലമേഷൻ കൊണ്ടാണ്, മ്യൂക്കോസൽ ഇൻഫ്ലമേഷൻ കൊണ്ടാണ്. അതേസമയം അലർജിക് ഫംഗൽ റൈനോസൈനസൈറ്റിസിനകത്ത് ഫംഗൽ ഹൈഫ ഉണ്ടാവും. അപ്പോ ഒരു ഇൻഫ്ലെയിംഡ് ആയിട്ടുള്ള മ്യൂക്കോസയുടെ അകത്ത് ഫംഗൽ എലിമെന്റ്സ് ആകത്തെ. ഈ ഫംഗൽ എലിമെന്റ്സിന് അതിന്റെ അകത്ത് മിനറൽസ് കൂടുതലാണ്. മാംഗനീസ്, കാൽഷ്യം തുടങ്ങിയ മിനറൽസ് കൂടുതലായതുകൊണ്ട് അത് CT സ്കാനിനകത്തുള്ള അതുകൂടെ പോകുമ്പോൾ ഹൈഡ്രജൻ അയൺസിനെ കൂടുതലായിട്ട് വലിച്ചെടുക്കും. അതുകൊണ്ടാണ് ഈ ഫംഗൽ എലിമെന്റ് അവിടെ കുറച്ചും കൂടെ ഒരു ഹൈപ്പർ ഡെൻസ് ആയിട്ട് കാണുന്നത്. So there is an isopacity, along with that there is hyper intensity. So we call it as an heterogeneous opacity or a double density shadow. Or we can also tell it as a starry sky appearance. അപ്പം ആ സ്കൈക്ക് നമ്മളൊരു ഹോമോജനസ് ലെവൽ കൊടുക്കുകയാണെന്നുണ്ടെങ്കിൽ അതിനകത്തുള്ള സ്റ്റാർ പോലെ ഒരു heterogeneous opacities കാണാം. So this is very typical of an allergic fungal rhinosinusitis. Okay. So homogeneous opacity in any polyp, whether it is an androgonal polyp or ethmoid polyp, heterogeneous opacity or double density in a CT scan is very typical of an allergic fungal rhinosinusitis. And there is also a Bend and Kuhn diagnostic criteria for allergic fungal. AFRS is allergic fungal rhinosinusitis. So major criteria and minor criteria. Major criteria, that is a type 1 hypersensitivity associated with nasal polyp. Characteristic CT finding, which is a characteristic CT finding, it is a heterogeneous opacity or double density or starry sky appearance. And there is an eosinophilic mucin without invasion and positive fungal stain. Staining of the nasal secretion will be positive for fungus. And minor criteria are asthma, unilateral disease, bone erosion, fungal culture. Fungal stain ആണെങ്കിൽ അത് major ആണ്. Culture is minor. And we can also see a charcoal laden crystalline serum eosinophilia. Okay. Eosinophilic mucin without invasion is major. Serum eosinophilia is minor. So there are major and minor, which is called Bend and Kuhn diagnostic criteria for allergic fungal rhinosinusitis. And you can also see the characteristic heterogeneous opacity in case of CT scan, nose and PNS. So the question is, there can be multiple questions you can expect. One is a 42-year-old diabetic, and this AFRS will be more seen with the elderly and diabetic also. Present with nasal obstruction, a CT scan of the paranasal sinus reported as showing opacification of the right maxillary sinus with double density signals. പിന്നെ double density എന്നുള്ള വേർഡ് വന്നു കഴിഞ്ഞാൽ പിന്നെ അതിനകത്ത് ഒരു കൺഫ്യൂഷനും ഇല്ല. The likely pathology is AFRS. Okay, allergic fungal rhinosinusitis. Aspergillus ആണ് കൂടുതലായിട്ട് കാണുന്നത്. Which of the following is not a part of Bend and Kuhn major criteria to diagnose AFRS? ഏതാണ്? Positive fungal culture, type 1 allergic reaction, nasal polyposis, CT scan of sinus showing double density opacity. ഇപ്പൊ തന്നെ നമ്മൾ പറഞ്ഞാണല്ലോ പോസിറ്റീവ് ഫംഗൽ കൾച്ചർ അല്ലേ? പോസിറ്റീവ് ഫംഗൽ കൾച്ചർ മേജർ ക്രൈറ്റീരിയ അല്ല. പോസിറ്റീവ് ഫംഗൽ കൾച്ചർ മൈനർ ക്രൈറ്റീരിയ ആണ്. സി, പോസിറ്റീവ് ഫംഗൽ കൾച്ചർ ഇസ് എ മൈനർ ക്രൈറ്റീരിയ ആൻഡ് പോസിറ്റീവ് ഫംഗൽ സ്റ്റെയിൻ ഇസ് എ മേജർ ക്രൈറ്റീരിയ. സോ പോസിറ്റീവ് ഫംഗൽ കൾച്ചർ ഇസ് എ മൈനർ ക്രൈറ്റീരിയ. Yes, very good, excellent. So the answer is positive fungal culture. CT scan showing an important area of the nose. Identify. ഇതാണ് area. Important area on the lateral wall of nose. ഏതാണ്? Nasal valve ആണെങ്കിൽ മൂക്കിന് അകത്തോട്ട് വരിക, ഇവിടെ വരിക എന്നല്ലേ? Inferior meatusന്റെ inferior turbinate and the septum. Columella is columella is usually an outer part between the two vestibule. Nasal septum അല്ല. പിന്നെ ഏതാണ് വരുന്നത്? The answer is osteometal complex. Osteometal complex നമ്മൾ നേരത്തെ പറഞ്ഞ കാര്യമാണ്. Osteometal complex ആണ്. അതിനകത്ത് കൺഫ്യൂഷൻ ഒന്നും ഇല്ലല്ലോ. ബാക്കിയൊന്നും നമുക്ക് ഇതുപോലെ CT സ്കാനിനകത്ത് ഇമ്പോർട്ടന്റ് ആയിട്ട് കാണാൻ പറ്റില്ല. It is the osteometal complex, which is the key area of a functional endoscopy sinus surgery seen in the middle meatus. A patient of suspected sinusitis has undergone CT scan of paranasal sinus, coronal cuts. CT scan shows an unusual cell marked with arrow. Identify it. It is answer 1. Bulla ethmodalis ആണ്. അതിനകത്ത് കൺഫ്യൂഷൻ ഒന്നും ഇല്ല. അല്ല, മീൻ കോങ്ക ബുള്ളോസ. സോറി, ഇറ്റ് ഇസ് കോങ്ക ബുള്ളോസ. You can see that this is middle turbinate. ഇതായിട്ട് കമ്പയർ ചെയ്യൂ. ഇത് nasal septum ആണ്. Okay. And this is the inferior turbinate and this is a middle turbinate. See, and it's the orbit, lamina, ethmoid cell. And here you can see the crista galli going into the skull base. Then Here is the cribriform plate also. So it is coming from the ethmoid bone and it is hypertrophied and pneumatized. Pneumatized ആയതുകൊണ്ടാണ് അതിനകത്ത് എയർ ഈ സീറ്റിക്കകത്ത് എയർ ബ്ലാക്ക് ആയിട്ടാണ് കാണുന്നത്. So it's a hypertrophied and pneumatized middle turbinate which is called conga bullosa. Bulla ethmoidalis ഞാൻ നേരത്തെ പറഞ്ഞു ഇറ്റ്സ് ആന്റിരിയമോത്ത് ethmoid cell ആണ്. ഏകനേസ എന്ന് പറയുന്നത് usually it is seen on the floor of frontal sinus. It will be more towards the floor of frontal sinus. Onodi, we know that it's usually in the axial cut. ഈ coronal cutനകത്ത് onodi കിട്ടില്ല. Axial അല്ലെങ്കിൽ sagittal cutനകത്തായിരിക്കും onodi വരുന്നത്. And it is in relation to the optic nerve. So it is in the axial cut. Onodi is usually seen in the axial cut. ഈ coronal cutനകത്ത്, if it is an hallux cell, you can see in the coronal cut. Conga bullosa, you can see in the coronal cut. Bulla ethmoidalis, you can see in the coronal cut. But onodi cells are mostly seen in the axial cut. So here the answer is conga bullosa. And we'll stop with this radiological signs. One is thumb sign, very typical of epiglottitis. See here, this is X-ray soft tissue neck and the epiglottis. Epiglottis നമ്മൾ ഐഡന്റിഫൈ ചെയ്യേണ്ടത് മാൻഡിബിൾ മുകളിൽ വരും. പിന്നെ ഹയോയിഡ് ബോൺ, സി ദിസ് ഇസ് എ ഹയോയിഡ് ബോൺ. അപ്പൊ ഹയോയിഡ് ബോണിനെ ഓവർലാപ്പ് ചെയ്തുകൊണ്ടായിരിക്കും എപ്പിഗ്ലോട്ടിസ് ഇരിക്കുന്നത്. ആൻഡ് ഇഫ് ദ സോളർ എപ്പിഗ്ലോട്ടിസ് is more like a thumb. So that is called thumb sign. And this thumb sign is typical of epiglottitis. And in an AP view, you can say steeple sign. Steeple എന്ന് വെച്ചാൽ പള്ളിയുടെ ഒക്കെ മുകളിലേക്കുള്ള കൂർത്ത ഭാഗത്തിനാണ് സ്റ്റീപ്പിൾ എന്ന് പറയുന്നത്. അതുപോലെയാണ് subglottis will be edematous and narrowed. And below that will be normal airway. അതുകൊണ്ടാണ് അത് steeple sign എന്ന് പറയുന്നത്. Steeple sign typically seen in croup, which is an acute laryngotracheal bronchitis. So the pathology, organism of epiglottitis, organism causing croup, then the management of epiglottitis, management of croup, ഇതെല്ലാം important ആണ്, അത് വായിക്കണം. So steeple sign is seen in acute laryngotracheal bronchitis. Thumb sign is seen in epiglottitis. Then Holman-Miller sign, അങ്ങനെ ഒരു sign ഉണ്ട്. It's also called Andral sign. This is seen in juvenile nasopharyngeal angiofibroma. What is it? See, there is anterior bowing of the posterior wall of maxilla. Okay, you can compare with the other side. So this is a posterior wall. Here also posterior wall. It is anteriorly pushed. So anterior bowing of the posterior wall of maxillary sinus, because there is this angiofibroma is sitting in the posterior part of maxilla. So that is called as a Holman-Miller sign or the Andral sign. This is typically seen in a juvenile nasopharyngeal angiofibroma. And the delta sign, this is delta sign. Delta sign is seen in sigmoid sinus. You can see it here. So that is seen in sigmoid sinus thrombosis, seen in a contrasenile CT. Thrombosis ഇരിക്കുന്നതുകൊണ്ട് അവിടെ ഒരു ഫില്ലിംഗ് ഡിഫക്റ്റ് വരുന്നതാണ്. empty delta sign ഉണ്ട്, delta sign ഉണ്ട്. ഇതുപോലെ ട്രയാങ്കിൾ ആയിട്ട്, this is delta. That is seen in a sigmoid sinus thrombosis, also called a lateral sinus thrombosis. So delta sign is seen in lateral sinus thrombosis. Holman-Miller sign is seen in juvenile nasopharyngeal angiofibroma. Thumb sign is seen in epiglottitis. Steeple sign is seen in acute laryngotracheal bronchitis or croup. Teardrop sign. See, ഇതൊരു teardrop sign ആണ്. ഇത് ക്ലിയർ ആയിട്ട് അറിയാം, ഇത് ഓർബിറ്റ് ആണ്, ഇത് ഓർബിറ്റൽ ഫ്ലോർ ആണ്. ഓർബിറ്റൽ ഫ്ലോറിൽ ബ്ലോ ഔട്ട് ഫ്രാക്ചേഴ്സ് വരും. ട്രോമ വന്നിട്ട് ബ്ലോ ഔട്ട് ഫ്രാക്ചേഴ്സ് വരുമ്പോൾ അതിനകത്തുള്ള ഫാറ്റ്, ഓർബിറ്റൽ ഫാറ്റ് മാക്സിലറി സൈനസിനകത്തോട്ട് ഹെർണിയേറ്റ് ചെയ്ത് വരുമ്പോൾ we call it as a teardrop sign. So teardrop sign is seen in orbital floor blowout fractures. Okay, teardrop sign in orbital floor blowout fractures. 35-year-old male presented with epistaxis. Conservative management was done to stop the bleeding, but it failed. What will be the next step in the management? So conservatively they mean as nose picking ആവാം, അല്ലെങ്കിൽ antinasal packing ആവാം. അതൊന്നും ഇല്ലെങ്കിൽ we do a endoscopic sphenopalatine artery dilation. Okay, so stop here. It is 9:30. Maybe we are going, because there are so many questions in ഇനിയും കുറെ ഉണ്ട്. നമുക്കൊരു ക്ലാസ്സും കൂടി ഇനി എപ്പോഴും കിട്ടുകയെന്നുണ്ടെങ്കിൽ, ബൈ ചാൻസ് ഇതെങ്ങാനും ഇനി നീട്ടുകയൊക്കെ ചെയ്യാന്നുണ്ടെങ്കിൽ നമുക്ക് ബാക്കിയും കൂടെ പോവാം. ഓക്കെ, സോ സ്റ്റഡി വെൽ. അവസാനമായി എന്ന് വിചാരിച്ചിട്ട് സ്ട്രെസ് ആവണ്ട. ഉള്ളതെല്ലാം പഠിച്ച കാര്യങ്ങൾ കുറച്ചും കൂടി റിവൈസ് ചെയ്യാൻ നോക്കൂ. ഒരുപാട് വൈഡായിട്ട് വായിക്കാതെ ഏതെങ്കിലും കൺസൈസ് ആയിട്ട് ക്വസ്റ്റ്യൻസ് ചെയ്യാം. MCQs ചെയ്യുമ്പോൾ ഹൈ yielding ക്വസ്റ്റ്യൻസ് കാണും, അതെല്ലാം കുറേം കൂടി നോക്കാം. അങ്ങനെ ചെയ്തിട്ട് കൂളായിട്ടിരിക്കും. ഓൾ ദ ബെസ്റ്റ് എല്ലാവർക്കും. നിങ്ങൾക്ക് ആവശ്യമുള്ള സ്പെഷ്യാലിറ്റി തന്നെ കിട്ടട്ടെ. ഓൾ ദ ബെസ്റ്റ്, ഡു വെൽ. ഓക്കെ, ബൈ.